Good evening, sir.
Good evening.
Yeah, good evening. Good evening.
We'll start the session shortly, so we are waiting for all the faculties.
Sure, sure.
Good evening, Vivek sir.
Yeah, good evening, Sudeep. How are you? All well?
I'm all well, sir.
Yeah.
Sudeep, sir, could we start with the session?
Sure,
Uh,
sure.
okay, sir. Thank you, sir. So, a very good evening once again. On behalf of International Association for Integrated Oncology, it is my pleasure to welcome you all to today's IAIO Expert Insights Breast Cancer Conclave. Today's scientific meeting brings together renowned oncology experts to discuss the latest evidence and practical approaches in the management of breast cancer, with a special focus on HER2 positive and metastatic disease. We sincerely thank all our distinguished faculty members for taking time out of their busy schedules to share their expertise with us. Without further delay, let us begin today's scientific proceeding. It is now my privilege to introduce our esteemed program director for today's conclave, Dr. Sudeep Das, HOD and Senior Consultant, Medical Oncology from Manipal Hospitals, Kolkata, West Bengal. Dr. Das has been instrumental in curating today's scientific program. May I now invite Dr. Sudeep Das, sir, to deliver the opening session titled Context Setting and Overview of Breast Cancer. Sir, over to you, please.
Yeah. Thank you, Ms. Roshni, for giving me this opportunity and giving me this platform of IAIO. I want to thank every team member of IAIO for giving me this platform. So, without further delay, let's start my first introductory presentation. Uh, So why it's important to remain updated about the treatment management of breast cancer and across all the stages, because the breast cancer is the most common cancer in India. So if you combine all the cases among Indian male and female, then breast cancer is the most common cancer in India. Uh, let's look at the world picture. Even the Globocon data shows that breast cancer is the most commonly diagnosed cancer in world. 2.3 million new cases of breast cancers are diagnosed every year, and of these 2.3 million, around 6.85 lakhs deaths are attributed to breast cancer. So, of all the new cancer cases diagnosed in women globally, 25.8% are breast cancer patients. 32% increase in age standardized risk from 2019 to 2035. And so it's very evident that this is what is the problem burden, disease burden in India, in world, and now coming to Asia. In Asia also, look at the data of India. This is the most common cancer across all genders, and of course in females as well. This is the most common cancer. Um, Somehow in India, somewhere around 19.5% patients are from India. about from breast cancer related mortality, 31% mortality in India is breast cancer related mortality across all the breast cancer related mortality in Asia. So that is because not only in India, the problem burden, the prevalence is also high, but most of the patients, they are diagnosed in locally advanced or even in advanced stage. So that is why the not only the prevalence, incidence, but also the breast cancer related mortality is majorly shared by India in Asia. We know that breast cancer is not a single disease. There are three subtypes: hormone positive, mostly we further subclassify as luminal A and luminal B. Then we have HER2 positive breast cancer, and we have triple negative breast cancer. The most common is hormone receptor positive. Together, luminal A and B, they constitute 70% of breast cancer. HER2 positive breast cancer constitute around 15 to 20%. And triple negative breast cancers are somewhere around 10 to 15%, and this type is the most aggressive type. Recently, there's a lot of enthusiasm and advances in the HER2 low, and now we have another nomenclature, HER2 ultra low. So the most of the HER2 low entities are actually they comes under luminal A and luminal B. And luminal A and luminal B, we all oncologists are well versed with that how they are differentiated. It is according to the Ki-67 level. This is evolving landscape in HER2 positive breast cancer. So currently in early stage HER2 positive breast cancer, they deserve neoadjuvant systemic therapy, particularly any tumor more than 2 centimeter or node positive, they deserve neoadjuvant HER2 directed therapy. However, in less than 2 centimeter size tumor and non-negative tumor, they can also undergo surgery upfront. Now, the patients who are undergoing neoadjuvant therapy, still now the standard was that dual HER2 systemic therapy, HER2 based trastuzumab, pertuzumab based dual HER2 blockade. However, there are recent advances in also in this segment also. Will in this today's program we will witness that. Coming to advanced HER2 disease, it depends on that whether the patients had upfront CNS disease or no upfront CNS disease. There's a lot of advances in this setting also. The standard of care till very recently, before DBU09 got published, was that the Cleopatra regimen was the standard of care for almost 1 decade. And it was the Cleopatra regimen now, and followed by second line Destiny Breast 03 TDXD. But now there's after the recent publication of Destiny Breast 09, now the landscape of treating a HER2 positive MBC first line is also changing very rapidly. The TKI also molecules also has a role to play, particularly tucatinib and neratinib. What is the evolving landscape in TNBC? In non-metastatic setting, there's incorporation of immune checkpoint inhibitor, and that is across all PDL1 score patients. However, in metastatic setting, most of the benefit of IO, incorporation of IO depends on the PDL1 CPS score, and uh, it also the treatment of metastatic TNBC also depends on whether the patient is BRCA wild type or BRCA mutant, because in BRCA mutant there is role of PARP inhibitor as well. Now there is lot of recent advances happened in this setting also TNBC, where um, patients who are not eligible for IO or even who are eligible for IO, there is another option of treatment like with ADC, and which in subsequent presentation Dr. Vivek Agarwala sir, he will elaborately present that data of ADC in TNBC. So, what is ADC? We all know that ADC is just an antibody drug conjugate. There is a payload. That payload has a cytotoxic activity. There's a stable cleavable linker, and once this ADC binds to cytoplasmic membrane target, then it gets internalized, and inside lysosome it gets detached. The payload is detached, and the payload actually, that is the cytotoxic agents which actually is responsible for cell killing. But this payload often diffuses out of the cell and permeates in the surrounding cells, and they can kill also surrounding cells as well, so which is bystander anti-tumor effect. So these are the timeline of ADC innovation in breast cancer. We had one of the initial ADC was TDM1, then we had trastuzumab deruxtecan, which is a very noble agent, and it was breakthrough in treating HER2 positive, HER2 low, now in even HER2 ultra low. Now we have different group of ADCs like sacituzumab govitecan and other ADCs also, for which is shown like Dato-DXd, which is they are shown efficacy in TNBC or in treating in HER2 negative MBCs. So with this, I want to thank you all for everyone who have joined in today evening, and over to the organizer to invite the next speaker.
Thank you, sir. Thank you very much for setting the perfect context for today's discussion and providing an excellent overview of the current breast cancer landscape. We now move on to our next scientific presentation. Our next scientific session is titled Integrating ADCs in Clinical Practice for Management of MTNBC by Dr. It gives me great pleasure to invite Dr. Vivek Agarwala, Director, Medical and Hemato-Oncologist, Narayana Super Speciality Hospital, Kolkata. Dr. Agarwala, the virtual podium is yours. Sir, over to you, please.
Um, I hope all of you can hear me well. Just let me put my presentation. Just give me 1 second time. Yeah, I hope all of you can see the slides and all of you can hear me well.
Yes, sir.
So, once the context has been set so wonderfully by Dr. Sudeep, my task here is that in the next 10 to 15 minutes, I'll talk you through about the ADC paradigm that has arrived now in the field of triple negative breast cancers. Also, we have seen how the ADC paradigm has changed management in HER2 positive breast cancers, but in triple negative breast cancers also. Now, we have this ADC paradigm, and that is what I'll concentrate on. Chiefly talking mostly about the datopotamab deruxtecan, which is very shortly will be launched by AstraZeneca. So, we all know, just as Dr. Sudeep already alluded to, is how breast cancers, amongst all the different types of breast cancers, triple negative breast cancer has the worst prognosis. And if you can look at uh, the bar curves on the right side, you can see that the survival in a distant metastatic by 5 years is a very, very poor, dismal 13%, which is the worst of all the three different types. In HR positive as well as HER2 positive metastatic breast cancers, we have almost nearly, a median survival of close to 5 years, and nearly about 40% to 50% patients are expected to be alive by 5 years, whereas this is only 13%. Even in the loco-regional disease, what we see is nearly 30 to 35% patients who are going to relapse very early within the first 2 or 3 years. And the median overall survival in advanced triple negative breast cancers, especially in India, where there is difficulty in access to drugs, it's almost 1 year to 1.5 years in average. Now, if you look at the management of metastatic triple negative breast cancers, the days of the year, we just only had chemotherapy. And we all know single agent chemotherapy was found to be just as good as a double agent chemotherapy. Single agent chemotherapy, uh, double agent chemotherapy did give a progression free survival advantage and a higher response rates as compared to single agent, but was not shown to consistently improve overall survival. And that is why, because you hardly have durable responses when with chemotherapy. The response rates varies around 25 to 30% in single agent, and going ahead to almost 50 to 60% in double agent. But in patients where we required faster response, where higher load of disease with good PSV and younger age, we used to always give double agent, and single agent was reserved for patients with lesser volume of disease and having not, comorbidities or not tolerating chemo that well. But post chemo progression, it was again chemotherapy, chemotherapy, and chemotherapy, and there was hardly any other kind of treatment that we could go to. And post progression treatment outcomes were not really optimal in triple negative breast cancer. Add to it the added toxicity and cumulative toxicity of repeated chemotherapy and continuation of chemotherapy. Again, there was a study that if you continue treatment versus you give breaks in the treatment, continuation of treatment has better survival. And that is why there has been a constant struggle in triple negative breast cancers in order to maintain the density, intensity of chemotherapy treatment versus the toxicity. And we have all struggled with in this era. Now, in the past decade, now we have had significant changes to the treatment in triple negative breast cancer. And now the management in triple negative breast cancer is more organized with the integration of immunotherapy in the first line, with the integration of PARP inhibitors in the first line, and now even ADCs are there in the first line option. So now in the last decade, what we have evolved to, if you look at, so we need to do biomarkers now in triple negative breast cancers upfront, because uh, uh, there will be a good considerable number of patients who are going to be eligible for immunotherapy. Now, if you look at the Keynote 355 study, I think this was the most convincing and most, universally accepted study, which clearly gave us the role of immunotherapy. Keynote 355 showed that in patients who had PDL1 high with a CPS of 10 or more only, they had a significant PFS advantage with addition of pembrolizumab to chemotherapy, almost a 4 months improvement in PFS with a hazard of 0.66, and which even converted into an overall survival advantage of close to 7 months, from 16.1 to 23 months, with a hazard of 0.73. And first time we had some treatment leading to a median overall survival reaching 2 years in triple negative breast cancer. We all know pembrolizumab addition to chemotherapy, hardly there are any major toxicity concerns. And withholding your chemotherapy, you can prevent your toxicities and let maintenance pembrolizumab go on. Yes, uh, if the PDL1 score is less than 10, then it is clearly shown from the post hoc analysis that the benefit of pembrolizumab goes on decreasing, and beyond, if you go less than 5, then there is hardly any benefit for pembrolizumab, so that the cutoff for use of pembrolizumab is kept at 10 or more. Whereas in our own practices, we tend to use it, because of the various reasons, heterogeneity in reporting CPS scores, and so on and so forth, to around 5 to 10. Also, other immunotherapy molecules like atezolizumab have not been consistently, shown to improve outcomes. We have all known about the Empower Breast studies, where overall survival was not, improved by addition of atezolizumab to nab-paclitaxel. But then there are other pros and cons of this study, which might be discussed, in another forum. Then there is also some data about toripalimab, irrespective of the PDL1 to be used, which may be also discussed in some other forum. But then there are now immunotherapy molecules to be used, especially in your PDL1 positive. Now, what remains for the PDL1 negative is you also have to do a germline BRCA and a somatic BRCA for these triple negative breast cancer patients. And patients who have a germline or a somatic BRCA, they are also eligible to be treated by PARP inhibitors or platinum upfront. Now, even in the immunotherapy era, if you look at the real world outcome, this is the outcome from the DREAM TNBC study, which reflects the real world outcome. And there also, what you see is that even in the PDL1 positive cohort, you have a median overall survival in the real world close to 18-19 months only. So in the real world, the outcomes are still dismal despite existence of your immunotherapy, largely because of the access issues and also because of a considerable heterogeneity that is there in reporting of the PDL1. At least in India, we are still struggling to find patients with PDL1 positivity in triple negative breast cancers. Uh, our positivity rates are close to 10% or less than 10%. We are hardly finding patients who are having CPS 10 or more. uh, on the contrary, in the West, it has been reported that the PD-1 positivity is close to 40%, which we are still to achieve in our patients. Maybe there is some heterogeneity in our patients, maybe there is some lag in the pathologist reporting, but then this is an issue. And then there are, because of these real world issues, I think the outcomes are still not there in the real world as compared to the Keynote 583 study. So what are the other options if the patients are BRCA wild type and PDL1 negative? And there now is the ADC paradigm. So we all know, in the second line, sacituzumab govitecan has been established as the standard of care in the past 6-7 years, but the access issue is still there. We are still not having sacituzumab govitecan being available and marketed in India. And with the Ascent-03 study, now sacituzumab govitecan has moved up the ladder to first-line treatment in all triple-negative breast cancers who are PDL1 negative and germline BRCA wild type. Now, competing the Ascent-03, there is Ascent-04 coming, where they are going to combine sacituzumab govitecan with pembrolizumab in PDL1 eligible patients also. That is there something that we'll have to see, and probably will also establish another standard of care. But and there is already a trastuzumab deruxtecan that is existing for our HER2-low patients in second line or later ones. But now there's another antibody drug conjugate called datopotamab deruxtecan that has slowly moved up the ladder from your later lines to second line to first line with the Tropion Breast 02 study, which was recently presented at ASCO. And this is what we'll discuss: is that datopotamab deruxtecan as a first line ADC option for our PDL1 negative germline BRCA wild type patients. Mind you, we'll also have a Begonia study later on, which will combine datopotamab with durvalumab in our PDL1 positive patients in frontline. And then you also have a SAC TMT, sacituzumab TMT with pembrolizumab as the first line in the Profuse 011 study. But as of now, what the good news is that datopotamab is going to be accessible and earlier accessible as compared to sacituzumab govitecan for our Indian patients very soon, thanks to AstraZeneca. So what is datopotamab deruxtecan? It is a specifically designed antibody drug conjugate. The payload is still the topoisomerase 1 inhibitor deruxtecan, which is same as that of the trastuzumab deruxtecan. And datopotamab, as we all know, is the antibody which is directed towards TROP2. And TROP2 is expressed in your triple negative breast cancers, as well in advanced breast cancers, almost in 70-80% of your cases and patients. And this is not actually dependent upon TROP2 expression. You don't need to measure the TROP2 expression in order to give this treatment to your patients. We have already used datopotamab deruxtecan previously as a part of clinical trials of tropion breast. We have used in hormone receptor positive setting in the later lines, also in our clinical trial, and now we have the tropion breast 4 study where already we are giving datopotamab with durvalumab in neoadjuvant setting in our triple negative breast cancer, looking at PCR as responses, which is also something that will come. So datopotamab binds to the TROP2. The whole complex is endocytosed, internalized, lysosomal degradation takes place, which sort of digests the linker, which is enzyme sensitive, and it is not stable as compared to sacituzumab, which is not so stable and which can be sort of released earlier on also. This upon this release of this linker, which is digested, the payload is then now released, which causes sort of toxicity to the tumor DNA thereby, and then this permeable payload is also sort of goes on to affect other nearby tumor cells, irrespective of whether they have TROP2 or not, by having a significant bystander anti-tumor effect. That is how it acts on. So this is the tropion breast 02 study. It was a phase 3 randomized open label multi-center study of datopotamab versus investigation choice of chemotherapy as first line treatment for locally advanced inoperable or metastatic triple negative breast cancers who are not candidates for immunotherapy upfront. So these patients, they were treatment naive, immunotherapy naive, not eligible, and they were having good PS. And these patients were randomized 1:1 to receive datopotamab standard dose of 6 milligram per kg 3 weekly against investigator choice of chemotherapy, and they had included many choices as per the discretion, like paclitaxel, nab-paclitaxel, capecitabine, eribulin, carboplatin, whatever single agent which is the standard. Now, they had stratified the patients based on the geographic regions, whether the patient had PDL1 high, CPS more than equal to 10 versus low, and what was the DFI if the patient had been treated earlier for an early stage less than equal to 12 months versus more than 12 months. The primary endpoint were dual overall survival as well as the progression-free survival by a blinded independent committee review. And the key secondary endpoints were PFS, overall response rate, duration of response, and safety. So this is the primary endpoint result. And clearly something again historic in the first line, you see almost a doubling of the PFS from a median of 5.6 months to 10.8 months, 5.3 months delta in the absolute PFS gain with a p-value which is significant, a hazard of 0.57. Also, what you see is that the difference at the end of 1 year is close to 25%, which remains 16% at the end of 1.5 years. So you see that both the curves, they remain the descent. They are not, sort of falling upon each other at the end, so that this PFS, significance is maintained throughout. These are the, subgroup analysis. And as you can see from the forest plot, except PDL1 high patients who are more eligible for immunotherapy, and where you see that the numbers are very small, all other patients, irrespective of whether they had a DFI of less than 12 or more than 12, what was their PS, race, age, whether they had high volume or low volume disease, whether they had brain metastasis or not, whether they had liver metastasis or not, all these patients had significant benefit with upfront datopotamab deruxtecan as compared to an investigational choice of chemotherapy. This is the investigator assessed PFS, and this also is similarly in favor of datopotamab deruxtecan, and more so favorable as compared to the blinded independent committee review, where also you get the similar differences. This is the overall survival, which is another endpoint, and clearly you see that there is a gap between the two curves, and even at the end of 18 months, there is a 10% difference in patients who are exposed to upfront to datopotamab deruxtecan, and the median overall survival here also is close to 2 years as against 1.5 years. So almost 5 to 6 months improvement in median overall survival with a very good and modest hazard of 0.79. Now, these are the response rates, and the response rates also you clearly see that the complete responses are almost 4 times, and the partial responses are also doubled from 26 to 53. Stable disease are lesser here, and progressive disease is much lesser. So the overall response rate is significantly better by almost double, 29% to 62%. This is again the overall safety summary, and what you can see is that the median duration of treatment with datopotamab is much higher. Uh, Patients who have been exposed to more than 12 months is almost 35% of them. And if you look at the grade 3 adverse events, so any adverse events are similar across both arms, but if you look at the grade 3 or more adverse events, they are also similar, 33% versus 29%. And those adverse events which are associated with dose interruptions are also similar, 24% to 19%. Those reductions seem to be a bit higher with datopotamab deruxtecan, and that is because of the peculiar toxicities, and discontinuations are much less, 4% versus 7%. So what you can understand is that the toxicity wise, datopotamab deruxtecan is similar to what your toxicity chemotherapy can offer, but in the long run, probably the quality of life is going to be better because you are not going to continue on to the chemotherapy, and your PFS, OS are better. These are the common adverse events, and these are class specific. We all know that dry eye is one of the features, and you have to use eye lubricants and ointments, and ophthalmologic examination, something you have to go ahead with. Mucositis, nausea, vomiting, constipation, and myelotoxicity are something. Neuropathy is much less here as compared to what you get with sacituzumab govitecan, and alopecia, fatigue are again there, which are again same with trastuzumab deruxtecan, and mostly alluded to the deruxtecan moiety, that is the topoisomerase 1 inhibitor. But if you look at all these toxicities, if you look on the right hand side, the grade 3 toxicities are less than 1%, less than 5% always, except mucositis, where the grade 3 incidence is around 8%. Again, the treatment-related adverse events. So just as I said, if you look, the most of the adverse events are grade 1 and grade 2, and these, mucositis as well as the ocular surface-related, events, most of them could be easily managed by, supportive care, dose interruptions, reduction. Discontinuation was required in, less than 1% or 0% patients in the datopotamab arm. This is again another analysis for additional efficacy endpoints like treatment to first subsequent treatment failure, PFS2, and treatment to second subsequent therapy, which are all surrogates for overall survival. So we know that the overall survival benefit looks to be modest, and one of the main reasons here can be exposure to other ADCs like in the control arm. So almost 35% patients were exposed to ADCs even in the control arm later on also. But if you look at the other surrogate endpoints, they also are very significant, telling you that the survival benefit with this molecule looks to be a bit more real. So this is the TFSC curve, time to first subsequent therapy or death, again doubled with a hazard of 0.49. Time to second progression or death, that is PFS2. So the efficacy seems to continue to your second line treatment also with a hazard of 0.61, and improvement by almost 5 months, from 11.8 to 15.6 months. And time to second subsequent therapy or death is also, you can clearly see a 4-month improvement to 0.67. So this is the post treatment data, and as I said that 33% patients were actually exposed to trastuzumab govitecan in later line, trastuzumab deruxtecan in 15% of patients, and 74%, 75% patients did get next line of treatment, whereas less ADCs were there, and less TDXT were there in the dato-DXT arm, which might be the reason why OS is not so significant and remains modest at 0.79. This is again the curves, and you can clearly see how the blue plot really sort of is ahead of the green plot in this swimmer's plot. So these are the key takeaways, that with the improvement in TFST, PFS2, time to second subsequent treatment with dato-DXT as compared to chemotherapy, is consistent with the dual primary endpoints of OS and PFS, and the total data supports that dato-DXT as a first new first-line standard of care for our metastatic triple-negative breast cancer patients for whom immunotherapy is not an option. Now, although this is something which is not a standard and cardinal sin in oncology, let us look at what are the differences in the sacituzumab govitecan and dato-DXd data by ASCENT-3 and dato-DXd. So we all know as a molecule both are sort of similar, but we are deruxtecan as a payload is much more sensitive and requires as a much less IC50. So the IC50, which is the least dose required for a greater sensitivity of action, is 0.31 as opposed to 2.78, which is required for your SN38, which is the payload here. Because again, the linker is enzymatic here, so it is more stable in plasma, whereas the linker here is pH dependent, and therefore it may be unstable in the plasma, which may lead to more systemic toxicities as compared to dato-DXd. Bystander effect is there with both the molecules, but what you see is that the half-life of this payload is much higher, 4.6 days as compared to 15.3 hours, and that is the reason why you just have one dose in 3 weeks for dato-DXd, whereas sacituzumab requires a day 1, day 8. That is higher administration, which leads to a higher cost also and a higher visits also. This is again the comparison, and clearly you can see, although this is not something a standard of care, but if you look at the response rate, 62% versus 48% with sacituzumab, PFS 10.8 versus 9.7 slightly looks better. Hazard 0.57 versus 0.62, OS 23.7 versus 21.5. Duration of response in higher number of patients. Median duration of response 12.3, 12.2 similar. So what you can clearly see that both of these drugs are there in your ADC for first line, but there are certain advantages theoretically as well as data wise that you can clearly see with dato-DXd, and why probably when we have dato-DXd access, we don't know when we are going to have access to SG, but dato-DXd very soon is going to be accessible, and it will be there for use. We look at the adverse event profile also. Grade 3 adverse events in dato-DXd 33% versus grade 3 adverse events with sacituzumab 61%. So clearly, there is higher myelotoxicity, there are higher dose interruptions, there are higher dose reductions that you see with sacituzumab govitecan, and this is something that we'll need to keep in mind when both the molecules are available. And the data with safety as well as the efficacy and some of the theoretical data does suggest that in comparison to sacituzumab govitecan, probably the first line ADC war is won by dato-DXd. At least in India, it is much easily accessible now. So probably our vote should go to dato-DXd. So with this, I thank you all for patient listening. And if there are any questions, I'd be happy to. Thank you.
Thank you, Dr. Agarwala, for that insightful presentation and for highlighting the practical role of antibody drug conjugate in management of metastatic triple-negative breast cancer. So if any of the participants is having questions, kindly drop your questions in the chat box, which will be addressed later on. So now we proceed to our next expert lecture. Our next topic is redefining outcome in 1L HER2 plus MBC with ENHER2 with perzumab. Now, I would like to invite Dr. Ghanshyam Biswas, Executive Director, Consultant Medical Oncologist, First Hospital, Bhubaneswar, and President of IAIO. Sir, over to you, please.
So thank you, Roshni, and good evening all. So moving from a triple negative to HER2 positive on MBC, and we are talking about combination of pertuzumab and ENHER2. So HER2 positive breast cancer patients have a high risk of relapse. So if you see on the left-hand side, so before trastuzumab, so all patients of HER2 positive, you can see the rates of relapse. So when trastuzumab was introduced, so you can see the rates of relapse significantly came down. So that was the effect of adding an anti-HER2. So we owe our present to the pioneering works of these three gentlemen who gave us the insights from the lab from the bench to bedside. So Dr. Ulrich, Dr. Slaman, who was a clinician, and the pharmacology guy, Dr. Schaefer, so who helped us in the HER2 journey. And people like her for believing the work. So this is Barbara. So Barbara Bradfield. So she was the first woman to receive trastuzumab way back in 1992, and she was the first patient in the clinical trial of Dr. Slaman. So she underwent, she had a HER2 positive disease, which has relapsed and spread to the lungs. So with trastuzumab, so she undergoes a complete remission in 1993. And in 2010, when the book by Siddharth Mukherjee was published, The Emperor of All Maladies, so she featured into that. So she, at that point of time, she was more than a decade of cancer-free. So now the therapeutic armamentarium for HER2 positive breast cancer is getting crowded. And as an Indian, we are lucky that there are so many biosimilars are also available, and all the new drugs, ADCs from TDM1 to the NR2, so these are all available with a PAP support for our patients. So mechanism of action of trastuzumab and pertuzumab. So if you see this cartoon, so pertuzumab and trastuzumab, they work on a different domain of HER2, and the second B group is all the ADCs, so TDM1 or trastuzumab deruxtecan. This cartoon will also help us understand that trastuzumab plus pertuzumab is not only an addition, but they are synergism, because trastuzumab binds on subdomain of 4, whereas pertuzumab binds on subdomain of 2. And that's how, so there is a complete block, near complete HER2 pathway inhibition. So that's how from a single agent trastuzumab anti-HER2 to a dual agent became the fashion. So if you see, the patients with HER2 positive MBC historically faced poor prognosis until the introduction, as I showed you, of a HER2-directed therapies. So trastuzumab from the Slaman trial, so was approved in the first line. So it took 14 years. So Ram Rajya, so Banvas, so 14 years to get the new regimen in the first line, that was THP. We know that trastuzumab, then pertuzumab along with taxane, so became. So it took another 14 years exactly to get the newer one in 2026. So NR2 plus pertuzumab, so is the new. So from moving from trastuzumab to dual anti-HER2 agent, and then so ADC plus anti-HER2. So this is how, so there was a significant improvement in terms of first line in a metastatic setting of HER2 positive. So if you see the patient, so why it is important? So it is important for all cancers in a metastatic setting. So how do you sequence your patient? Because as you go on the disease progresses at each time, so there is a drop of patients for the second line and the third line because of performance status and because of the associated comorbidities. So now what is the difference between a de novo HER2 MBC versus a recurrent HER2 positive MBC? So if you see from the systematic reviews of HER2 positive registries, so as compared to de novo, then recurrent, so de novo is a better subset than compared to a recurrent. Recurrent means more than 6 months after the neoadjuvant adjuvant treatment. So de novo will more likely to have a longer survival as compared to a recurrent one, less likely to have a baseline brain metastasis, more likely to have baseline bone or liver metastasis. And importance is that a de novo patients will less likely to have HR positive disease, because today we want to have a maintenance treatment. If it is HR positive, you go the patina way. If HR negative, then you go the tucatinib way. So as compared to de novo and recurrent, so PFS is almost 18 versus 12 in favor of a de novo metastatic HER2. And that's the importance of picking up a de novo HER2 metastasis, a metastatic disease versus a recurrent metastatic disease. So de novo HER2 positive is also associated with improved survival and lower CNS burden. So median OS was not reached in a de novo versus a recurrent by 44 months with hazards of 0.55. If you look at CNS metastasis, put together all the patients, so you can get a 9% patients with a CNS metastasis, whereas de novo will have less than 5%, whereas in a recurrent settings, you can get up to 14% patients will have a CNS disease. So that's how the patient outcome differs, de novo versus a recurrent setting. So HR negative tumors typically demonstrate a worse prognosis compared to a HR positive. That has been shown in this D Placido slide, that HR positive will do good today because probably the biology is different. And today in 2026, we know that so there are maintenance. So you can bring back hormones and then probably you can improve the survival. So visceral and brain metastases are prevalent in patients with HR positive, HER2 positive MBCs are associated with the reduced survival. So because visceral metastasis involves soft tissues like soft internal organs like liver, lungs, and digestive organs, almost 50% of the patients at presentations will have these organs at the site of metastasis. Liver metastases are more common and that heralds a poor outcome. And also important that somebody who has a liver metastasis is a risk factor for developing a brain metastasis. I don't know the reason, but this had been there. So somebody who is in a liver metastasis, so you can get a brain metastasis. Jaidev, please mute. So expected to have almost 25 to 50% patients with HER2 positive as a brain metastasis. We know that they have a poor outcome if there is a lot of disease in the front brain and the posterior part. Though it is considered as a late event and occurring almost 2 to 3 years following, that's why in a recurrent setting you get a more amount of brain metastasis. In Cleopatra trial, so 14% of the patients develop brain metastasis at the first site of progression. So after Cleopatra, so what were the unmet needs? So lack of first-line advancements after Cleopatra. So recurrent disease were doing bad as compared to the de novo one. Visceral metastasis and brain metastasis were challenged because you needed a drug so that can penetrate the brain. And HR status. So with the subsequent HR positive, we knew that so if you go the patina way, adding an CDK4/6, that improves the survival. And if they are HR negative, then you go the tucatinib way. So that is how these were challenges some time back. So now looking at the current treatment landscape of first-line HER2 positive MBCs. So since 2012, so we know that dual anti-HER2 with the taxane was the standard. So almost 14 years passed. Then and with this, we knew that 50% of the patients will come back with the disease, and that how so you needed something or some treatment better than the existing Cleopatra. And their Destiny-Breast09 came as a boon, which was a major advancement in the first-line HR2 positive MBC setting, addressing a long-standing unmet need for last 14 years. So this is the Cleopatra. So Cleopatra absolutely established the clinical superiority of dual HER2 blockade with trastuzumab and pertuzumab. You can see so 18.5 versus a 12.4 when we are using a single anti-HER2 agent. So that's how it established in 2012. So this is 2026 guidelines. So this is, you can see it is getting crowded. If you look at focus on the first line, so Cleopatra is already there. So after Cleopatra, you can put the patient on a maintenance in the patina, so where you can add hormones and CDK4/6. If your patients cannot tolerate docetaxel, so you can change the taxanes, and that was the per use, and then you can maintain in a patina way. And the new approval has been DB09. So what we'll be discussing today, so TDXD plus pertuzumab, though it is a category 2A regimen at this moment. So as the data matures, so we'll see more climb this regimen climbing up the ladder. ESMO 2026 also now recommends TDXD plus pertuzumab as category 1A, so MCBS2 for first-line HER2 positive MBC, regardless of the HR status. So on the left-hand side, you can see the ER positive, so where TDXD pertuzumab has been in the block, so as a 1A, and even in the ER negative, so you can have so TDXD plus pertuzumab as a 1A recommendations. So Destiny Breast 09 aims to address multiple unmet needs, which we talked about in the HER2 positive MBC therapeutic landscape. So patients with brain metastasis were excluded from the Cleopatra trial. And also I said, so 14% of these patients actually had brain as a first site of progression, omitting a significant population that is included in the Destiny Breast 09. And this study also provides data to support the use of TDXD in first line to improve outcome for patients with HER2 positive MBC, including those with a brain metastasis. Also provides data that support the potential prevention of brain mets with TDXD, because we know that if these patients survive long and if these patients are exposed to radiation, so cognitive function decline is an important quality of life aspect. Destiny Breast 09 will stratify patients into de novo versus recurrent, HR status positive versus negative, and PIK3 mutant detected versus not detected. So the rationale for combinations of pertuzumab with TDXD, so we initially saw how trastuzumab and pertuzumab were different in the different domains of HER2, and this is how the pertuzumab, so which is an monoclonal antibodies in the HER2, whereas TDXD so is an ADC with a different mechanism of actions, and a lot of these are because of the bystander effect. So inhibition of cell proliferation and survival because of the inhibition of PI3K pathway, standard bystander effects of these ADCs, and apoptotic cell death of once this TDXD gets internalized. So coming to the trial proper, so it had more than 1,100 patients. So and metastatic HER2 positive BC breast cancers, HR positive or HR negative were included. So disease-free interval of more than 6 months from the treatment of in a curative setting. One prior line of endocrine therapies were allowed, except no other systemic therapies were allowed, and good performance status. So exclusion criteria, because this drug can cause an ILD. So anybody who has an ILD and on steroids, they were excluded. Significant cardiac comorbidities and symptomatic brain mets were excluded. Patients who are more symptomatic beyond performance status of 1 were excluded. So the randomization was into 3 arms, 1:1:1, and as I said, so there were full 3 stratifications. So the new arm, that was the experimental arm, was Enhertu plus pertuzumab 3 weekly, and the THP, the Cleopatra regimen, and the third arm was Enhertu alone, and these results has to be updated. So we expected that Enhertu alone is not going to be probably superior to any of these both regimens. And the treatment until disease progression or unacceptable toxicity, the primary endpoint was PFS by BICR, and secondary endpoint was OS. And the other endpoints have been overall response rate, duration of response, PFS2, and a safety and tolerability. So if you see the endpoint here, so primary endpoint, which was median PFS, 40.7 versus 26.9, a huge 13-14 months of difference with the hazards of 0.56. And if you see the secondary endpoint, which was OS, so again, the data was immature because at the time of patients only 16% maturity. So separation between the PFS curves began early 6 months and increased 12 and 24 months from 93 versus 88 versus 86 versus 72, and at 2 years, at 24 months, you can see 52 versus 70. So if you look at the consistent PFS benefit across, be it a de novo or recurrent, be it a hormone positive or negative, so PIK3 did not matter much. Brain metastasis, if not symptomatic, so did not matter much in the terms of responses and previous exposure to. So these were not relevant. So definitely, if brain mets were there, so they had a hazards of 0.30. And looking at the other aspects, so prior exposure to endocrine therapies or anthracyclines in the curative setting did not much difference. So all favored the experimental arm of NR2 plus pertuzumab. So also clinically meaningful improvement in the PFS too. So median PFS was not reached with NR2 plus pertuzumab as compared to 37 months with the THP. And so patients who received post-continuation therapy in second line. So again, you can see a TDM1 in 6% patients in the experimental arm, whereas 26% in the THP arm. And the other regimens were 63% trastuzumab containing arms, because these patients, the experimental arm was not exposed to that, whereas 28% in the THP arm. And many patients also received chemotherapy and endocrine therapies also. The safety signals by this time we are used to because of pertuzumab and Enhertu. So we know, so these drugs, so they need to be you need to be very vigilant, especially for any cardiac dysfunctions or ILDs, and Enhertu can also be, so you need at least triplet regimens in terms of taking care of the CINV. So dose modifications were used to help manage adverse reactions and keep patients on treatment with NR2 plus pertuzumab. And so dose reductions 45.9% with NR2 versus 20% with THP. We know that, so with the potent drugs and because of the bystander effects, so you are going to have some amount of additional toxicities. Dose interruptions almost 70% versus 50%. Discontinuation 20% with NR2 versus 28. So which was in favor, which is lesser in the experimental arm. So the median duration of treatment around 21 months in the experimental arm versus 16 months, 17 months. Patients still receiving treatment almost 46% versus 33%. The majority of adverse reactions were grade 1 and 2, and no new safety signals after including both the drugs. So because of pertuzumab, you can get some amount of diarrhea, which is, I think, is manageable. So the key takeaways is that persistent unmet needs remains in HER2 positive MBC. So after a hiatus of almost 14 years, we have moved from Cleopatra to DB09, and so NR2 plus pertuzumab significantly improved progression-free survival. So clinical benefit was consistent across all the patient subgroups, and enhanced efficacy was achieved with a manageable and predictive safety profile. And most importantly, probably, so there is a prevention of these patients having a brain metastasis. So thank you for a patient sharing. So over to the organizers. Thank you so much.
Thank you, sir, for an excellent presentation and for sharing the latest evidence in the first-line HER2 positive metastatic breast cancer. Now we shall move on into our expert discussion. It is now time for our expert discussion on re-imaging first-line HER2 positive metastatic breast cancer, which and HER2 pertuzumab to transform survival outcomes. To moderate this discussion, it is my pleasure to invite Dr. Chandrakant sir, academic head and senior consultant, medical oncologist, hemato-oncologist, and BMT Narayana Super Speciality Hospital, Kolkata. Joining him on the panel are Dr. Kaustav Majumdar, Dr. Shreya Malik, Dr. Ankur Bhattacharya, Dr. Avinash Pandey, Dr. Nihanti S., Dr. Pralay Basu, Dr. Devdeep Samadar. Over to you, Chandrakant sir.
We don't have Dr. Chandran, is it? It's there in the agenda.
Ma'am has not joined, sir.
Okay, so we will go in this order. So it was a wonderful talk by Kancham sir. I think he already pointed out very important aspects of frontline therapy of metastatic breast cancer. So I thank Dr. Sudeep Das for this wonderful opportunity uh, to share my few thoughts on the frontline management of HER2 positive metastatic breast cancer. So it's more of a discussion. There are multiple competing options in the front line. So let us best understand how to choose one over the other. So I will start from Dr. Kaustav till Dr. Devdeep Samaddar in the same order as it is there in the agenda. Okay, so re-imaging frontline HER2 positive MBC. So this is how we will go through case study, current landscape, unmet needs, TB09, and then the summary. Okay, let's start with the case study. 50-year-old hypothyroid, breast cancer, left PCS, 4EC, 4 PACLI, LRRT, and then letrozole. Okay, and then now at 55, 5 years, in presence with dry cough, difficulty in breathing, palpable left breast mass with axillary lymphadenopathy. So this is breast imaging. 2.1 PET CT, lung nodules. Now it is HER2 positive. There are multiple lung metastases. This is a frank metastatic disease. So it's a hormone positive, HER2 positive metastatic MBC with the previous history of EC, PACLI, and letrozole. Okay. So I think the patient was on letrozole because it's just 5 years. So let's keep that in mind. So there we go. So ultrasound guided core biopsy of the left breast mass is this 90% ER, 30% PR, HER2 3+, MRI brain is negative. Well preserved patient. So Dr. Kaustav, let me start with you. It's a HER2 positive metastatic breast cancer with the history of HR positive breast cancer. What are your options among this, Dr. Kaustav?
Yeah, so good evening, everyone. So here, if you can see the options here, the induction chemotherapy followed by maintenance HP or the second option, and the TDXG pertuzumab. So coming to the, if you can consider the science here now. So recent publication of the DB09 when the PFS data, as already mentioned in the last speaker, is really excellent. The PFS is around 40 months. Where in Cleopatra, it is only PFS, if I'm not wrong, 18 months, 18 to 19 months. So there is a big difference between these two. So if science is the factor and also there is no affordability issue of this patient, then I should consider for here the TDXG plus pertuzumab in this patient.
Excellent. So you would consider Destiny Breast 09 as an option. Good. Thanks, Dr. Kaustav, for sharing your opinion. So, Dr. Kaustav, if I went on to ask you the follow-up question, why not the second option?
Yeah, so yes, absolutely. So you are considering the PATINA trial here, where the induction chemotherapy followed by maintenance HP and endocrine along with the CDK4/6. There is also an option of this, but if you can consider the PFS data of the PATINA versus TDXG plus pertuzumab, it is also better in this DB09 trial. And if you can see the various subgroup analysis of the HR positive disease, it is also well preserved with respect to the other factors. So that's why we might consider these things. But yes, absolutely, PATINA is a good option in this patient.
Right. So I think both are fair, but important thing to remember is Destiny Breast 09 is for all students who have got 35% marks, 50% marks, 90% marks. Whereas Patina is only for people who have cleared the exam. They have got an entrance exam of having some response to the THP. If they have not cleared the entrance exam, they are not qualified for the for the exam.
So you have a checker there. You need to tolerate 4 to 6 cycles of THP. And remember, in Patina, 10% people after getting screened, I mean, they were screen failed in the waiting period because they were progressive. So that's the key. So that is some nuance. We will discuss more into the comparison of these. So Patina is after an entrance exam, whereas DB09 is for all comers. That's the point. Okay. Chalo, let's go further. We have a long way to go. So this is NCCN. Of course, NCCN recommends every regimen that has got a randomized trial that is positive, where you can see THP, you can see Patina, you can see Conclave, everything is there. So we have to choose among all, and this is the ESMO. Even the ESMO also has got DB09 being there, and this is Cleopatra. Overall survival was phenomenal, like 57 months, right? So, Dr. Shreya, so overall survival is there with Cleopatra. DB09 has no overall survival yet. So, does this make you choose Cleopatra over DB09?
Good evening, everyone. So, sir, if we compare end-to-end these two trials, definitely the DB09 doesn't have the overall survival. But as you have said, it includes all the types like brain metastasis and all. And as the HER2, especially HER2 positive metastatic breast cancer, has very high propensity for the visceral mets and the brain mets, so definitely, and the TDXT has a CNS penetration, so definitely it is a good choice. But again, the traditional Cleopatra regimen is always a better option. It is actually, I will not say that DB09, I will just, if I get a patient tomorrow, I will choose DB09. I will go for the Cleopatra only. But again, it has a better result in terms of every subset if we see the DB09. So Cleopatra is also a very good acceptable option if we see the overall survival data.
Right. So Cleopatra has been there with us for 10 years,
Yes,
So,
it is a
so
trustable.
right.
Uh,
So if you a few more details, just reading some between the lines. So this is in the era where after progression, right? After progression, the control arm did not get TDM1. TDM1 was not accessible.
yes, sir.
And number two, in the TDXT era, you have the control arm. A lot of patients in the control arm did get ADCs at progression. And number two, the follow-up time. And number three, if you take the control arm of DB09, I think it's there in future slides. If you take the control arm of DB09, it should be Cleopatra.
Yes.
The control arm of DB09 has a PFS of, I think, 24, 25 months.
25 months.
Right? Whereas the Cleopatra PFS is 18 months.
18 months.
The same Cleopatra in 2025-26 is doing well because of endocrine therapy optimization. So, and imagine today in the present era where 40 months is the PFS. PFS is 40 months, right? And imagine these patients are eligible for subsequent lines, okay? TDM1 is not cross-resistant. You can use TDM1, you can use Conclave. So if you use these, I think clearly it will bypass the 57 month of overall survival. And the control arm will have access to ADCs. So I think keeping all this in mind, so DB09 had a more robust control arm, which was not controlled. It got access to ADCs at progression and the PFS itself. So Cleopatra has a PFS of 18 months and the OS is 57 months. And now DB09 has a PFS of 40 months. Imagine the PFS, OS. I think the OS will be like 70, 80, something
70.
somewhere there.
Yes.
So I think almost doubling of the OS. Right. So let's, I think already Dr. Shreya answered this. Experience with THP is good. We all have experienced THP. People go on with THP for quite long. We have all good experiences. Right. So, in Dr. Ankur, let me come to you. Is there any challenge you face with THP regimen in the present practice?
Currently, sir, yes, we have so many biosimilar molecule available, so it is quite acceptable to all my patients. But issue was that in past years, due to high cost, the majority of patient we cannot offer the pertuzumab. But nowadays we are giving in more liberally on those patients, and they are tolerating as both clinically and as well as financially also. So I don't think so, sir. It is a very difficult molecule to prescribe. So TCP is a quite acceptable option, and we are giving day-to-day practices, sir.
Right. So, whenever we ask, if someone asks me in a panel discussion, how is your experience with, let's say, immunotherapy, pembrolizumab, nivolumab? Oh, wow, it's a lovely molecule, because very important is it's very well tolerated. We remember those patients who did so well because they keep coming again and again for signing and stamping. So I keep remembering them. Similarly, if someone has a PAP, they keep coming to you, right? So this is and what happened to those patients who progressed and died or who didn't follow up? It goes off from our memory. So this is called as a survivorship memory bias. I remember patients who keep coming to me. I forget patients who do not come to me. Probably if you collect any data, you will see, "Arey, itna sara dropout hai." I think I was just seeing the recent ALL story of India. I think 30% lost to follow. So we don't even realize. So when we ask a regimen, we remember from those patients who keep coming for signing. So we should be aware of the bias, and very important is it has no CNS protection. HP has no CNS protection, and the PFS, I mean, if you use endocrine, then probably the PFS is longer. But Palbo is not easy. They keep coming with neutropenia if I use Patina. So that is something that you need to remember. So where HP experience is good, but also think of patients probably who progressed. Right. Right. Now let's go to Hard to Climb 5. Wow, it was fantastic. Tucatinib, 24 months PFS. Hazard ratio is 0.6. That too after you get a response. Again, for Hard to Climb 5 also, you need to climb after 4 to 6 cycles. After you climb only, you will get the Hard to Climb 5. Till then, you have to wait. Right. So this is Patina. Again, here for Patina to be eligible, you need to first pass those 6 cycles. Okay, so now let's come to the core. Dr. Avinash, if I can request you, how would the regimen in Hard to Climb 5 and Patina be adopted in clinical practice?
Yeah, so both are having a very interesting data. If you see, the curves are getting separated quite early at the beginning of the maintenance only. So for a patient who is a HER2 positive, they would be continue to have maintenance with trastuzumab, pertuzumab, and they can add tucatinib. So adding tucatinib will have a higher CNS penetration, and the intracranial progression can be reasonably controlled with adding tucatinib for HER2. And for hormone positive, apart from hormonal therapy, AIs, we can add palbo to it, and palbo will further increase the progression-free survival in hormone-positive cohort of patients. So both are reasonably good options, and both are likely to transform the care of patients who are on maintenance TH, maintenance HP in these patients.
Right, sir. So let's focus on Hard to Climb 5, sir. So the toxicity of pH we face is diarrhea, and the toxicity of tucatinib is also diarrhea. So, Dr. Avinash, if I can request you the overlapping toxicity profile of this. So, how good is Tucatinib also diarrhea, PH also died. So do you feel any
Yeah, so
challenges in tolerance of HER2 climb 5?
I have seen more patients with pertuzumab getting diarrhea. In my practice, about one-fourth to even one-third of patients do complain of diarrhea. And often they are manageable with anti-motility agents and hydration, but still, I have seen patients, one or two patients getting admitted and requiring IV fluids for severe diarrhea because of pertuzumab. And adding tucatinib over pertuzumab can be challenging. So obviously, toxicity has to be closely monitored, and patient has to be explained that diarrhea could be a problem, and you have to report and start anti-motility drugs as early as possible, so we can decrease the severity and the incidence of diarrhea. But
Right.
this is an important point to be noticed.
And so, what do you think is the compliance to the full dose of tucatinib in those patients who are? So, the moment they receive PHP, they become symptom free. They're on HP, and the moment they take the tablet, they get diarrhea and they become worse. They have mucositis and all this. So, do you see giving full dose of tucatinib to a patient on
No,
PH?
so
I mean, as a
mostly of these
challenge,
patients, I reduce the dose to half.
right?
So with half dose, they are able to tolerate better.
Right. Right. That's very practical. You know, to replicate the HER2 climb 5 data, it's not easy because they were fitter patients and they had stricter ways of reducing the dose. So we take tucatinib as a side dish and not as a main dish, and therefore we reduce the dose and we give. That's the key. So that's the diarrhea problem. Okay, now let me go to Dr. Nihanti. Dr. Nihanti, let's focus on Patina. So, Patina, 40 months PFS, phenomenal. These are in patients who have got a good response to THP. Okay. And very importantly, if you remember the exploratory analysis of the Cleopatra, they looked into the PIK3CA mutant population. PIK3CA is around 30 to 40%. There, the PFS is like 12 months, okay, with the PH regimen. So, let's say a triple positive, I got a partial response or a stable, whatever response to the THP. And now, if the patient, 30-40% patients can have a PIK3CA in them. If there is a PIK3CA, even if I use a CDK4, my PFS is going to be shorter in the PIK3CA. And we don't have the subgroup analysis of Patina right now in the PIK3CA mutant. So, do you feel that if a patient also has a PIK3CA along with triple positive HER2, would you be cautious before you offer a Patina regimen to these patients?
Good evening, sir. Sir, definitely, sir. What you told, all the points are quite crucial. Whenever patient has a triple positive, we need to look which is the actually the targetable and the driven, which causes the biology of a tumor. So HR positive and HER2 positive, I think I think we would more incline towards HER2 positive biology. So I think first my target would be I'll focus on the HER2 part of it. Then when we are focusing the hormone component, definitely the subset of HR positive who had a PIK3CA mutation in them, they usually don't fare better. As you said that in Cleopatra, the subgroup analysis did show something, but there was like a defect in 8 months. Whereas if you're adapting the same here, sir, with Patina, I think I would be very cautious, definitely no doubt. But even even said it done, uh, especially in HER2 positive, I would first target the HER2 positive thing. If you're looking at the hazard ratio of this, it's 0.75. Actually, that we need to emphasize on. So definitely I'll be cautious in adding, but still adding palbociclib has given a benefit of 15 months. So I think I would still consider and still wait for further data to pop up, sir.
Very relevant points, Dr. Nihanti. So she did acknowledge that a triple positive is not a homogeneous subset. You have those PIK3CA mutant population who may not show that good PFS. And the hazard ratio of benefit is 0.5 for DB09 and 0.7 for Patina. And remember, only 30% of the DB09 patients got hormone therapy. Imagine if the DB09, everybody got hormone therapy, I think the PFS would have been longer than 40 months. So that's the fair understanding of the comparison between Patina and DB09. So PIK3CA mutant cannot be ignored We don't have the subgroup of PIK3CA mutant in the Patina trial. Okay, I think this we all discussed. Okay, so now Dr. Prolai, if I can request you, you're there?
Yes, I'm there. Yeah.
Hi, Dr. Prolai. So, Dr.
Hi.
Prolai,
Yeah.
if you look into the inclusion criteria of Cleopatra,
Yes.
there the trastuzumab free interval was 12 months.
Yes.
Okay? And none of them received previous pertuzumab because neoadjuvant, adjuvant pertu was not there.
Absolutely. Absolutely.
And there were
Because
no brain mets.
Cleopatra was in the metastatic and we start off in
Yeah.
the metastatic setting only.
Yeah.
Right.
And today, in the present day, a lot of patients are exposed to pertuzumab before.
Yes.
And brain metastasis was excluded,
Yes.
right?
Yes, definitely.
And
Yeah,
they,
absolutely.
so how do you see this? You know, DB09 did have brain metastasis. DB09 included patients who had up to 6 months of previous trastuzumab exposure was allowed,
Yes.
right?
Yes.
And previous pertuzumab was allowed. So how do you look into the inclusion criteria, which is more relevant for in the present day, DB09 or the Cleopatra?
So obviously, the DB09 inclusion criteria is more relevant in the modern era because simply because in the when we went for the when Cleopatra was done, these things could not be considered because of course pertuzumab was being tested in the metastatic setting. They did not have any idea whether it would come in the metastatic setting, let alone in the neoadjuvant or adjuvant setting. So it could not have been considered. Similarly with trastuzumab free period and all. And regarding brain mets, basically one of the reasons might have been that in the previous era, it was often considered that when a patient has brain mets, irrespective of symptomatic or asymptomatic, you go for radiation upfront. But here we have that concept where the patient is not having active symptomatic brain mets, we treat the systemic disease. We only go for a local therapy when it is causing significant disturbance. So, in that setting, in these settings, of course, the DB09 or the uh, hard to climb data are much more relevant because they take into account the unmet need.
Right, and even none of them got exposed to TDM1 before. You know, in the
Yes,
present day, we use
that is also
TDM1,
another. Yes, yeah,
TDM1
of
in
course.
the adjuvant setting also. So
Yes,
we have a
yes,
lot of
yes.
patients. I think none of the patients are there who do not receive at least a per two for some whatever duration we give in neoadjuvant and TDM1 and adjuvant. So these are the set of patients we are seeing today. We don't see a Cleopatra
Yes,
patient today.
yes.
Right. Okay, Dr. Dipdip, let's come to recurrent versus metastatic. They're a different population. Recurrent patients have seen the chemo, have seen the HER2 targeted therapies, right? Metastatic patients are the ones, de novo are the ones who are naive, right? HER2 climb 5 had majority of them de novo metastatic. They didn't have recurrent patients. Whereas DB09, if you see the subset, I think I have the slide. Both of them did extremely well as far as DB09 is concerned. So, what do you say, Dr. Dipdeep?
Yes, sir. So, as per the earlier retrospective data, we know that those patients who are recurrent actually do worse than de novo metastatic disease. Now, this remains a challenge in even after the Cleopatra data. Now, coming to the hard to climb and the recent DB09, obviously the preference will be DB09 because we know and we have seen from the subgroup analysis that DB09 in DB09, this patients, the recurrent patient in both those patients who have recurrent disease have did well compared to those who have de novo metastasis. So obviously my take will be on this population, sir.
Right. So, important point to remember, there was good representation of recurrent patients in DB09. HER2 climb 5 was enriched with de novo metastatic patients. And I just ask you to look into these curves. Look at the curves, 40 versus 26 from day one. Okay. This is do not compare the 40 of this with 40 of Patina. Patina had HR positive and those who had responded. Okay. You cannot compare the two. You can look into the hazard ratios and look at the comparator. 26.9 months is the neo I mean, is the new Cleopatra arm performing because of endocrine therapy? Endocrine therapy is important. Remember, only 30% of them got endocrine therapy. Imagine if everybody got endocrine therapy in this, they would have done much, much better. So that's the key. Okay, let's quickly go on to some toxicity part. Okay, so Dr. Kaustav, if I can request you, I have a challenge in giving TDXD, pneumonitis is like it damages the lung. It's very concerning in a patient who is I mean, THP is fantastic, not much pneumonitis, TDXD, pneumonitis is life threatening. So, how do you overcome this barrier of DB09 in your practice?
Yeah, important is the pneumonitis, that is, and whatever I have the experience with this TDXD. I faced a few patients with grade 3 pneumonitis also with TDXD. So that's why if when the patient is on follow-up, even patient is complaining some kind of at least respiratory problem or something, I should consider the patient for the HSCT thorax to see whether it is something is cooking or not. That is the main key of, that is the main key of the.
Dr. Nirmal, can you please mute? Yeah, okay. Go ahead.
So that is the main, the crux of this using the TDXD. So
Right.
that's why I should be a bit careful, but not like that each and every patient we have experienced with this pneumonitis and it is severe grade 3, grade 4, not like that. So might be less than 5% patient in our population might causing this grade 3 or grade 4 pneumonitis. So
Right.
a bit concerned of it, but yes, absolutely, it's not a very major safety issue, I would say.
Right. So I think also made a fantastic comment, how to monitor pneumonitis. So one thing we need to remember, the moment we say pneumonitis, what comes into our mind is that pneumonitis of a patient on pembrolizumab, nivolumab, or durvalumab who had breathlessness, white out on a ventilator, and we lose the patient. That's the mind we have. Or let's say a docetaxel pneumonitis where a patient. But remember, the pneumonitis we see with NHER2 is not that pneumonitis because none of the immunotherapy says I need to do a HRCT chest 8 to 12 weekly. So there it's a surprise pneumonitis in immunotherapy. Whereas in TDXT, it is an anticipatory pneumonitis. You hardly land up with grade 3, 4 because you are doing CT scan every 3 monthly, 2 monthly. So that surprise pneumonitis of a patient landing on a ventilator is rarely seen because here you don't wait for symptoms. You do proactively 2 to 3 monthly. So therefore you cannot, the moment I say TDXT pneumonitis, do not imagine a patient on a ventilator with a whiteout lung that you see with immunotherapy. There it is a surprise pneumonitis. All well, patient is on a ventilator, suddenly is gone. That you do not see with TDXT. You would see this after around 6 to 8 months median usually. But anyways, here it's anticipatory pneumonitis. And whenever you do an earliest CT finding without a symptom, it's called a grade 1 pneumonitis. There you would stop TDXT and you will give steroids for 6 to 8 weeks. If the recovery is before 8 weeks, you can reach another same dose. The recovery is more than 6 to 8 weeks, then you will go for one dose low. That's the way to handle TDXT pneumonitis and take out that phenomena of the surprise pneumonitis picture when you use TDXT. It is an anticipatory pneumonitis here. And number two, okay, DB09, I am concerned of pneumonitis. What about if I have to give DB03? I mean, second line, there I have to give TDXT. You cannot escape from the pneumonitis thing. You have to go through the protocol for monitoring pneumonitis. Okay. Okay, now let me go to Dr. Shreya. So more questions. I will give DB09 only in patients with heavy visceral disease. I will not give for patients who have a low disease burden. How do you look at this argument?
Sir, the low disease burden in HER2, usually the HER2 positive metastatic disease comes with a visceral mets. So as we see the DB09 inclusion criteria, So they have included all the variety of patients we can include as a metastatic disease, and irrespective all the factor, the DB09 has proved the efficacy in all the subsets. So it
Right.
is not that if the patient has a slow progress of the disease or low burden of the disease, we'll switch it to THP. In every subset of the patient, DB09 did well.
Correct. So the benefit of DB09 was irrespective of disease burden. That's what Dr. Shreya said. And let me ask, what is the criteria for high disease burden? Dr. Shreya, is there a criteria to say, let's say a patient has a breast mass, a small liver lesion, two bone lesions, and one lung lesion. Is it low disease burden, high disease burden? How will you define a disease burden? There is no definition, no?
No,
We
there
don't
is
know.
no no,
It's
no,
a
there
very
is no definition.
so
It is
one
actually individualized or depends
right.
on the symptom burden.
Right. The same patient may be a low disease burden for an oncologist and high for another oncologist.
Yeah, and
And
maybe the patient presents with a low disease burden, but after 2-3 months of THP only, they just develop the
yeah,
multiple site visceral
right.
mets.
So
So
disease burden is a very vague phenomena. It can change from person to person and from time to time with the same person.
yes, sir.
So selecting treatment based on disease burden is
No,
not
no, no, it is
validated.
not a basis.
Right. So Dr. Ankur, if I can request you, I will give TDXT for initial 4 to 6 cycles, and then I stop and I continue on trastuzumab or pertutrast2. How do you take this idea?
Sir, actually, wherever we start our treatment, our main target is to incorporate one chemotherapy drug along with trastuzumab pertuzumab combination. And if I go with TDXD, the same concept in a different formulary, we are giving the same. We are giving one payload, we are giving one anchor point, and we are giving one pertuzumab
What
along
if I
with
get
that.
a response?
Yeah.
I got a response and then I put them on trastuzumab or only pertutrast2 because it's expensive or maybe it's toxic. What do you say?
Uh, I won't go for that, sir. I will certainly continue the
Right.
TDXD because once this is good progression, somehow
Right.
then we again cannot bring back the
Right.
TDXD.
So then that's the way to go. Dr. Ankur, I think, is very correct. So this was answered in ASCO 2026. So they looked into TDXD plus PER2. When is the maximum response? Does the maximum shrinkage stop at 4 cycles? Does it stop at 6 cycles? Does it stop at 8 cycles? They looked into it. Chemotherapy maximum response is 4 to 6. After that, you don't get a response. The response is plateaued. They looked into the response of DB09, and what they saw was the median time to having a maximum response is 1 year and even beyond. 50% of them required 1 year to have the maximum response. And the remaining 50% continue to respond even beyond 1.5 years. So the moment we think of ADC, we should not think of them like chemotherapy because the shrinking continues even beyond 1 year, and stopping it before is like it's an unfinished job. So you cannot stop a drug that's working, that's reducing the disease burden, and the complete response that you're going to attain at 1 to 1.5 years is lost if I discontinue early unless you have a grade 3 toxicity. So that's what ASCO 2026 said. Okay, so I think I'll take 1 minute last. So Dr. Avinash, again I'm back to you. So let's compare TDXT versus tucatinib. Which is better for brain?
I think TDXD will take an upper edge because the data is because data is strongly supportive of TDXD, and if I given a choice, I will implement DB09 upfront rather than using tucatinib in secondary progression after the intracranial brain mets happen. So I'll prefer DB09.
Right. The hazard ratio for brain mets is 0.3 for DB09. I think it's 0.6 or 0.7 for tucatinib. That's the key. Right. So, okay, now let me go to Dr. Nihanti. Dr. Nihanti, if I use DB09 in first line, I don't have anything to use. I have exhausted everything. What will I give in second line? How will you look into it?
Sir, in second line, this patient would have upfront received TDXD with pertuzumab. Now I would again redo the molecular testing done to look into the HER2 profile and all. And if the patient is hormone positive, again, the main important thing, sir, I would look into the performance status of the patient, the disease burden, If the patient is in a high burden disease,
No,
I
no.
think
So you have got all the options. That's fair. But you know, I am losing out. No, there is no second line good option. So how do you overcome this thought?
there is no second line good option. But if you're looking into DB09, a PFS2 benefit was there. In that, the experimental chemotherapy arm and whatever the targets they
Right,
have reached, still
right,
PFS2 benefit
right.
was there. So
So
I think
I agree. The take home message is this: if I give DB09 frontline, it does not make the disease resistant to any treatment. You can give docetaxel, you can give hertucline, you can give even
anything.
TDM1. TDM1 and TDXD are not cross-resistant. Their payloads act differently. So whenever I sequence ADCs, if I am giving the same payload, it doesn't work. If I change the payload, it works equally well. That is the key. So TDXD and TDM1 are not cross-resistant, therefore can be easily sequenced. Okay, I think that's fair. We have completed the whole. Dr. Pralay, any other barriers, any other thoughts you want to share
Uh,
on DB09?
No, definitely. Whatever has to be discussed has already been covered. The DB09 data is actually quite encouraging, or rather, I would say it is remarkably encouraging because while we are on the topic of of discussing second line, basically, even the all the your point is well taken that all the second line options will be effective because there is no cross resistance and all. But even leaving that aside, the first line data, the PFS are, and considering that to be a surrogate for future OS data, that would the PFS data itself encompasses the first plus second line data for other regimens. So that is itself we are covering a lot of ground in that only. So even if the second line regime or subsequent line regimens are slightly inferior, they give a cumulative benefit is definitely maintained. So of course the
Right,
DB09 is the go-to option in the first line, definitely.
right. One point I missed out saying, Dr. Devdeep Pralay. So response rate equals survival. This you don't see with chemo because you lose the response.
Yes.
Whereas if you have a complete response or the deep response, there is something called as a deep
Deep response.
that they showed in astronaut. So those who achieved a deep PR, they used, I mean, 80% chance, I think they cross 4 or 5 year mark
Yes,
without.
basically there is a sustained response in these cases, like
Right,
we see in cases of IOs where the
right,
patients who are responding, they often show a deep and sustained response. Yeah.
right. So those who achieve a deep response, they continue to respond. That's the intensity. Yeah, Dr. Devdeep, your thought on response is a surrogate for PFS and of course overall survival.
Uh, I mean, not every time, sir, but definitely it remains one of the important
Not
surrogate.
it was not every time in chemo, but in ASCO 26 they have looked into the subgroup of deep PR and CR. Both of
Yes, sir.
them have shown a OS, not a OS, PFS. I think 80% people remain progression free for 3 to 4 years. So
Yes,
this
sir.
is the
Yes,
AD.
sir.
We need to develop the ADG mentality with a
Yes, sir.
heavy payload. This is not a chemo. So
Yes,
that
sir.
is what I was trying to stress.
Yes, sir. Yes, sir.
Right. Okay. So thanks, Dr. Devdeep, for
Thank you, sir.
sharing those inputs, and thanks all of you for active participation. So DB09 looks to be one of the most promising first line regimen with 40% with 40 months of PFS, which has been uncomparable. Thanks again for this opportunity.
Thank you very much, Dr. Chandrakant sir, for expertly moderating such a thought-provoking discussion. My sincere thanks to all our esteemed panel experts for sharing their valuable perspectives. Before we move on to our next scientific session, I would like to invite our program director, Dr. Sudeep Das sir, to share a few words on evolving role of Enhertu. Dr. Das, over to you, please.
Yeah, thanks to Dr. Chandrakant sir. I was listening to him He was moderating the session very beautifully. If he is still there, I have a question to Chandrakant sir. Chandrakant sir, do you have any reservation for using DB09 regimen in elderly patient who has not so good lung function, because the patient is going to take continue TDXT for a longer period of time? Do you have such reservation for using this regimen for very elderly patients? We get a lot of patients who are 70 plus and PS is not so good.
Right. I think a very, very relevant question, to Sudeep. So, what are the risk factors for TDXT pneumonitis? Exactly similar to bleomycin. Okay. The moment someone is elderly,
Renal
yeah,
function.
exactly similar to bleomycin. Has the compromised lung at a risk, renal function at risk. So just focus on the renal function. That's the key. If kidney is good,
In
lung is good, you can as well give. If kidney is an issue, then just be cautious. Maybe one level low or something like that. You have to dose adjust. But remember again, the pneumonitis is a anticipatory pneumonitis, not a surprise pneumonitis. That is the key.
Yeah, that's true. Though it's not supported by evidence, but are you tempted to use any hybrid kind of regimen in such situation that you debulk the disease with 6 cycles of DB09 regimen and then you switch over to patina or hard to climb 5 regimen in such patients? Though it's
Right.
not, I agree that it is not supported by level 1 evidence, but are you in real world scenario, real world practice, are you tempted?
Right.
Because I
So
want to highlight here that tucatinib is not lapatinib. Lapatinib has similar kind of action on both EGFR and HER2. So it has a lot of skin toxicity and diarrhea. We are using tucatinib, but we are not witnessing such diarrhea or hand-foot syndrome or skin reactions or paronychia, because it is more it's more specific to HER2 rather than HER1 or EGFR in such
right.
situation.
A very, very relevant thought. So why not I debulk and then I shift to a much lighter regimen? That's a fair one.
Mm.
So this is what all the international authors used to strategically put it before the ASCO 2026 presentation. In the ASCO 2026, what they showed was to achieve a maximal response. It's almost 1 year and beyond. So I am continuing these patients more and more and more, and you keep getting the response. So it's not like a chemo debulking I'm doing. I am going to have a sustained shrinking of the tumor over the period of years. So therefore, if I give 4 to 6 cycles and discontinue, it's an unfinished job. So people are now, rethinking about those previous thoughts because it's toxic. After 6 cycles, why not shift to pH with Tuka? People are saying that it's an unfinished job. 1 to 1.5 years, you will actually continue to get more and more CRs. So probably no, because if a drug is working in onco and if it's continuing to work, I would not shift. I would do it only if there is an intolerable toxicity or if there is a logistic constraint.
Sir, let me raise my one concern here that we are discussing ILD part, enormously, but ILD, all grade ILD was reported some across all the DB trials were somewhere around 12 to 13%, and that is all grade. Most of them were grade 1 or grade 2. Grade 3 was only 1 to 2%. But what we are not discussing significantly is a significant number of patients complain of fatigue. Fatigue is one of the major complaint because the payload itself is a cytotoxic drug, chemotherapy. So anyway, sir, in a real world situation, in your practice, what percentage of eligible patients, what percentage, suppose you have 100 HER2 positive MBC in your clinic every month, what percentage are taking from logistic point of view?
Right.
Because, sir, currently, because now I have been informed that in HER2 is now available in CGHS online formulary. So what is CGHS online formulary means that if that the drug is in CGHS online formulary, so the empanel patients, they need not appeal to the Central Advisory Board of Delhi at New Delhi. Earlier, any CGHS empanel patients who are taking high-end molecules, they have to appeal to the New Delhi board, and if they only approve, then the patient can get the medicine, which will take at least 1.5 months get the approval. Now it can be approved by the local body as well because it is now in CGHS online formulary. Sir, Chandrakant sir, what percentage of your patients are actually eligible in real practice, sir?
And that's a practical question, Dr. Sudeep. So my lower doses are mainly for logistic reasons. So if those
Yes,
patients
yes, sir.
who are able to have full dose access, probably they are receiving, maybe we do divide into 1 or 2 days for the insurance and West Bengal health scheme purposes. Day 1, day 2, day 3, day 1, day 2. So this is what we are doing. But for logistics, we do give a lower dose. I think Dr. Minakshi from our hospital presented the lower dose data of 3.8 per kg, and we showed we showed a response that's fine, that's good enough. But I think the it's not like immunotherapy.
Sir, you
It's
must
not
be
immunotherapy.
knowing, sorry, you must be knowing Dr. Prabhat Bhargav is also doing an
Right,
ICMR funded trial in low dose
right.
TDXD at
From
TMH as
what
well.
I understand is ADCs are not like immunotherapy. Immunotherapy saturation happens with lesser dose, but here there is a relation between the dose and response, and there is preclinical data where dose reduction reduces the responses. So I'm not sure that a reduced dose is as effective as a standard dose. In those patients who cannot have access because of logistic reasons, there I would give one level low, but not usually as a practice. But in immuno, we use it a little liberally. But in ADC, I think we should be cautious before we do that.
Thank you. Thank you so much, Chandrakant sir, for your insights, valuable insight. Thank you. Over to Roshni again to continue the program. Thank you.
Thank you, sir. Thank you, sir, for those insightful remarks. We shall now continue with our next scientific presentation. Today, Dr. Paula Mibasu will share a compelling real-world case study showcasing an exceptional clinical response using Enhertu in a patient with brain metastasis and HER2-positive MBC. Her insights will be highlight how advancing targeted antibody drug conjugates are reshaping prognosis in real-world clinical practice. Please join in welcoming Dr. Paula Mibasu.
Thank you.
Paula
Kindly share
Mibasu
the
to
slide.
deliver her presentation.
Yeah, kindly share the slide from your end.
Hi, Roshni,
Kindly
you were
share this.
sharing the slide, right?
Yes, sir.
Yeah. Yes. Ma'am, just a minute. They would be sharing.
Hope the slides are visible, ma'am.
Yeah, just make it a full screen.
Yes, ma'am.
So thank you for giving me this opportunity. So it's a real world case. HER2 positive metastatic breast cancer patient had a baseline brain metastasis. So real world case study with Enhertu. Next slide. So 63 years old female with diabetes and hypertension and there was no significant history of breast cancer or any family histories there. So patient was diagnosed with invasive breast carcinoma on November 2021, and at that time her ERPR was negative, HER2 was 3 plus, IHC 3 plus. Next slide. So this particular patient undergone surgery first from outside and then received adjuvant therapy like 4-cycle doxorubicin plus cyclophosphamide followed by 4-cycle docetaxel plus trastuzumab. Then patient received adjuvant radiotherapy and completed 17 cycle of maintenance trastuzumab and then on observation. Next slide. So almost after 2 years, on January 2024, patient developed respiratory distress, and at that time PET-CT was done. It revealed patient there was bilateral lung metastasis, there was pericardial effusion, and there was nodal metastasis like bilateral cervical supraclavicular lymphadenopathy was there. Next slide. So at that time, repeat biopsy was done, and again it was HER2 positive and ERPR negative. So with start patient was on docetaxel, trastuzumab plus pertuzumab, and after fifth cycle of docetaxel plus trastuzumab plus pertuzumab, patient had some neurological complication. So we did MRI brain. We know it's a HER2 positive case. So we did MRI brain on May 2024, and it revealed there was multiple brain mets. And patient was symptomatic. So patient had history of seizure also. So patient received palliative whole brain RT. Next slide. Next slide. The patient, then this is our ESMO guideline. We know which we usually follow in our day-to-day practice. So for all HER2 positive metastatic breast cancer patient, if patient is symptomatic, then only we can use whole brain RT. Otherwise, we can use NHER2 because this particular drug has a very good brain penetration power, very good CNS PFS rate. So we can use TDHD for brain metastasis patient also. Next slide. So now coming to this Destiny-based 12 study. So it's a multi-center single-arm study where they only include HER2 positive metastatic breast cancer patient already received 2 line of therapy, and there were 2 cohorts. One cohort received they received TDHD with a dose of 5.4 mg per kg, 3-weekly schedule, and one cohort had baseline brain metastasis, and another cohort has no baseline brain metastasis. So Destiny-based 12, the primary endpoint was to see the PFS, and the secondary endpoint, there was additional endpoints like to see the overall response rate, which is important, that is CNS PFS rate, so to know the safety profile. Next slide. Now coming to results of Destiny-based 12. So it's a result, and you can see that this TDHD showed a consistent 12-month PFS benefit in patient with stable as well as active brain metastasis patient. So we can see that even if patients have active brain metastasis, we can use this TDHD safely and see the result. Median PFS was 17.3 months. So we are talking about MBC patient, metastatic breast cancer patient, and that too brain mets, with a median PFS of 17.3 months. Next slide. So now coming to CNS PFS, which is important because we are talking about brain metastasis patient. Again, there was consistent 12-month PFS in patient with stable as well as active brain metastasis patient. Next slide. So now coming to overall response rate, the other endpoint, again, you can see the response. Around 4% of the patient in overall population achieve complete response. So again, a brain metastasis patient achieve complete response according to this Destiny-based 12 data. Next slide. So again, you can see the TDHD showed a substantial response in overall population. So even if patients have active brain metastasis, we can safely use this drug. Next slide. So now coming to some cross-trial comparison, like ADHD versus HER2 we know that HER2 again they include brain metastasis patient, and in HER2 they use tucatinib along with trastuzumab plus capecitabine, and in destiny-breast they used PDHD. Now we don't have any head-to-head comparison, but we have this cross-trial comparison. See the PFS rate. PFS in HER2 it was 7.3 months, and PFS in Destiny Breast it was 17.3 months. So obviously the response or overall CNS PFS was almost, we can say, much more high in the Destiny Breast data. Next slide. So which is important, that is CNS overall response rate. You can see according to HER2 CNS overall response rate was almost 50%. It was 47.11%. And in according to Destiny Breast it was more than double. It was around 82.6. So we don't have any head-to-head comparison, but we have this cross-trial comparison where we can say that TDHD, as this particular drug had a very good brain penetration. So overall response rate, CNS PFS rates are much more. Even the 12-month PFS, if you see the HER2 data, it's 35%, whereas in Destiny Breast the 12-month PFS was almost double. It was 60.1%. So metastatic breast cancer patient, that too brain metastasis, overall survival, which is important. 12-month overall survival was almost 90.3% in Destiny Breast, and in HER2 where they used tucatinib plus trastuzumab plus capecitabine, the 12-month overall survival was 71.1%. Next slide. So now back to our real world case. So this particular lady, again after 2 years, developed metastasis with bilateral lung mets and nodal metastasis, pericardial effusion, initially on trastuzumab plus pertuzumab plus docetaxel. And again after 5 months, patient developed active brain metastasis. Patient had a history of seizure. Then after palliative whole brain RT, patient was on Enhertu since July 2024. And after 7 cycles of Enhertu, we did a PET CT scan and which showed that there was partial response. Next slide. So that was a PET CT report. There was complete even metabolic response to the metastatic site. Next slide. So we can say that this particular patient completed 15 cycles of Enhertu, and after 15 cycle of also there was a good disease control. The only issue we all know that Enhertu, this trastuzumab deruxtecan is a highly hematogenic drug. So this particular patient developed grade 1 nausea and vomiting, and we easily managed by nitipetin plus palanoseptal. Next slide. So coming to our conclusion, so the 63 years old female with diabetes and hypertension, with breast cancer, metastatic breast cancer, initially diagnosed on 2021. After 2 years of journey, this particular patient relapsed with bilateral lung metastasis, as well as pericardial effusion and nodal metastasis. So this particular patient received Daxin plus trastuzumab plus pertuzumab. After 5th cycle, again this particular patient developed brain metastasis on May 2024, and since June 2024, this particular patient received Enhertu, and even after a 15 cycle of Enhertu, there was a very good response. So this particular patient received TDHD as a third line therapy. And as we did a PET CT scan on November 2024, again, there was a very good response. So these are all about efficacy. Now coming to side effect, as I have already mentioned that this particular patient only developed grade 1 nausea and vomiting, which was managed with nitipetin plus palanoseptron. Next slide. So that's all I think from my side. So this particular patient did a very good response with TDHD. So I think with this, I conclude my talk. Thank you.
Thank you, Dr. Basu, for sharing those valuable clinical insights. Now, our next topic is when to introduce and how to sequence ADCs in the MBC setting. Now, I would like to invite Dr. Pradeep Mondal, who is the speaker and consultant medical oncologist from Manipal Hospitals, Kolkata, West Bengal. Sir, over to you, please. Sir, should we share the slides from our end, sir?
1 minute.
Okay, sir.
My slides are visible.
Yes, sir. But it should be on the full screen mode.
Okay. Yeah. Okay, so thank you. Thank you for giving me this opportunity, and thanks all respected dear colleagues who have joined in this academic evening. So today my topic of discussion is when to introduce ADCs in HER2 positive metastatic breast cancer. So basically, this is the point of a discussion in most of the guidelines that in NCCN and ESMO, that basically where do we introduce our ADCs in metastatic breast cancer in today's scenario. So this is the NCCN guidelines. If we see in hormone receptor positive or negative and HER2 positive disease, first line that DOSI plus PAR2 plus TAS2 is the category or preferred regimen. Category 1 recommendations, followed by maintenance trastuzumab and pertuzumab. And if hormone receptor is positive, then aromatase inhibitors plus minus palbo plus pertuzumab trastuzumab. And first line, they have also included that TDXD plus pertuzumab as other recommended options. And of course, in second line and third line setting, TTXD is the category 1 recommendations along with others like TDM1, KIP, or Bucartini plus trastuzumab are also preferred or category 1 recommendations. So this is the ESMO 2026 recommendations for TDXD plus pertuzumab as category 1A recommendations. And so if we see that previously untreated HER2 positive metastatic breast cancer, hormone receptor positive disease suitable for chemotherapy, then docetaxel plus pertuzumab trastuzumab being the choice. And the patient had a good response in the form of stable disease or objective response to continue maintenance pertuzumab trastuzumab, and along with endocrine therapy plus palbo is the preferred option. And others recommended options are TDXD plus pertuzumab is also in category 1A recommendations. If patient is not suitable for chemotherapy, then endocrine therapy plus trastuzumab or endocrine therapy plus pertuzumab trastuzumab. These are the options. So basically, what are the factors influence our choice of ADCs and the timing of introductions in our clinical practice? So if we see that the mutations in the PIK3CA gene are present in almost 30% of the HER2 positive tumors and drive the therapeutic resistance to multiple HER2 targeted agents. So basically, HER2 dimerizations leads to the activation of the PIK3CA signaling pathways, and PIK3 kinase phosphorylates the serine and threonine kinase AKTs. The serine threonine protein kinase mTOR subsequently serves as the downstream targets of the PIK3 and AKTs. Nuclear factors are then recruited and modulate transcription of the genes involved in the cell growth, metabolism, and survival. So, in Cleopatra, patients whose tumors expressed mutant PIK3CA experience shorter median PFS versus those with wild type expression in both the pertuzumab group, 12.5 versus 21.8 months, and control group 8.6 versus 13.8 months. Hormone receptor negative tumors typically demonstrate worse prognosis compared to the hormone receptor positive tumors. In a CR retrospective analysis of 47,000 patients with HER2 positive breast cancer, patients with hormone receptor negative disease demonstrated worse prognosis compared to that patients of hormone receptor positive disease. Hormone receptor negative breast cancers were of higher histological grade, larger size, had higher nodal involvement, and higher rates of de novo metastatic breast cancer compared to that hormone receptor positive breast cancer. And comparative OS analysis between hormone receptor positive and HER2 positive and hormone receptor negative and HER2 positive subgroups, that hormone receptor negative and HER2 positive 5-year OS rate is 78.8%. Hormone receptor positive and HER2 positive 5-year OS rate 84.2%. Visceral and brain metastases are prevalent in patients with HER2 positive MBC and are associated with reduced survival. So visceral metastasis in HER2 positive MBC involves soft internal organs like liver, lungs, and digestive organs, occurs in 47% of the patients at first presentation of HER2 positive metastatic breast cancer. Liver metastasis occurs at a higher incidence in HER2 positive breast cancer compared to HER2 negative disease and are associated with poor survival. Liver metastases are also a risk factor for developing brain metastasis. And brain metastasis in HER2 positive MBCs are expected to occur in 25 to 50% of patients with HER2 positive MBC. And diagnosis of CNS metastasis have increased over time, likely due to improved detections and longer survival associated with HER2 targeted therapies, and are associated with poor survival. And it's considered as a late event occurring in 2 to 3 years following initial metastatic diagnosis. In Cleopatra trial, 14% of the patients developed brain metastasis as the first site of progression following first line THP regimen. Prevention of brain metastasis in these patients is highly important due to their detrimental effects on survival and quality of life. So, with the advent of ADCs in earlier setting, basically the shift in guidelines where that ADCs move into that first line setting. So, evolution of TDXD in HER2 positive advanced metastatic breast cancer. And if we see that observed median PFS in first line, Destiny Breast 09 is a phase 3 TDXD plus pertuzumab. And Cleopatra, the standard of care, THP of 18.5 months. So in Destiny based 09, that median, observed median PFS didn't median PFS not reached, and when compared to that standard THP of 18.5 months. In second line, Destiny based 03, that TDXD versus TDM1 28.8 months versus TDM1 6.8 months. And in third line, Destiny based 02, compared to that treatment of physician choice, 6.9 months. So, and in Destiny based 01 phase 2 study, TDXD 16.4 months of median PFS. And it has been shown that 1 out of 3 patients do not receive the subsequent treatment after first line. So it's better to use the base drug in the first line only, because the TDXD plus pertuzumab have shown a significant median PFS, and almost 33% of the patient could not take the subsequent lines because of probably deterioration of the performance status or different other reason. So standard of care and future perspective in the treatment landscape of HER2 positive advanced breast cancer. So standard of care at that Cleopatra regimen, first line pertuzumab, trastuzumab plus taxane. No or stable CNS disease. Then in second line, TDXD, Destiny based 03. If progressive CNS disease happens, then tucatinib plus trastuzumab plus capecitabine is the choice. And later in the third line can be shift to TDXD. And for no brain mets or stable CNS disease, then TDXD in the second line, followed by in third line TDM1, or tucatinib plus trastuzumab plus capecitabine. Futures perspective are TDXD in the first line at the Destiny based 09 TDXD and TDXD plus pertuzumab, Destiny based 09. And in later line, that TDXD plus tucatinib, TDM1 plus tucatinib, or TDM1 plus atezolizumab. So what are the challenge with introducing ADCs earlier? DB09 toxicities, TDXD plus pertuzumab, overall no unexpected toxicities, 12.1% ILDs, including 0.5% death. So I think that this can be managed, though that ILD, all grade ILD is quite higher, but grade 3 or higher ILDs are less. LV dysfunction is 11% versus 7.1% in THP. Treatment related adverse events possibly associated with death in 5 patients. Overall, similar incidence of adverse events across all the both the arms, and discontinuation due to treatment related adverse event, TDXD 20.8%, THP 28.3%. More dose interruption or reductions with TDXD. During maintenance phase of Cleopatra regimen, few side effects and excellent quality of life. So that is the basically advantages of Cleopatra regimen. And of course that we are having the quality of life data from that DB09. So probably the toxicity is a concern of using DB09 in the first line setting. So early identification of ILD or pneumonitis is the key to appropriate management. We have to follow the 5S strategies to help detect and manage ILD or pneumonitis in patients receiving TDXD. So we have to screen properly, careful patient selection based on the baseline risk screening that continues during the treatment is required. So before initiating NR2, we have to be very strict identification of our patient to identify the any risk factors are there or not, any comorbidities which can hamper or which can augment that ILD. And throughout the treatment phase, we have to be very cautious and careful of the symptoms that may indicate ILD or pneumonitis. So we should not ignore the cough, fever, dyspnea, this kind of things. And whenever this kind of symptoms happens, we have to be very carefully investigate. And so we have to do the imaging, proper imaging of the patient whenever the symptoms are there. And of course, that multidisciplinary team opinions of pulmonologists, radiologists should be taken and should be properly managed. So that is very important when these patients on long-term TDSD. So very careful identification of ILD in maybe in the earlier phases can be life-saving. So that basically we have to suspend treatment when there is an that ILD or pneumonitis are strongly suspected, promptly to investigate the evidence and to interrupt the TDSD treatment as soon as possible. And for patients who have asymptomatic grade 1 ILD, to interrupt TDSD to wait for the results that symptoms if resolves within 28 days, instead to maintain the dose. If resolve more than 28 days from the date of onset, then to reduce one dose level. And if patient is symptomatic, get 2 or higher, then to permanently discontinue TDSD is very important. And corticosteroids is the cornerstone of treatment, and to consider using corticosteroids there are different dosing schedule for different grade of the patient. How to reduce the dose? Recommend the starting dose is 5.4 milligram per kg. First dose reduction is 4.4 milligram per kg. Second dose reduction 3.2 milligram per kg. And even after that toxicities happen, then to discontinue and not to re-challenge. So ILD can be severe, life-threatening, and fatal. So regardless of the severity and seriousness, ILD events would be followed until resolution, including the drug discontinuation. So if properly managed, probably TDXD, using TDXD in the first line and to continue in that long term can be successfully done. Otherwise, patients may develop this kind of toxicities, and that can hamper the quality of life. Thank you.
Thank you, Dr. Mondal, for an excellent presentation. Now we move on to our next scientific lecture, Advancing Care in HER2-positive Early Breast Cancer. And it's my pleasure to invite Dr. Soumya Surat Panda, Professor and Head Medical Oncologist, IMS in some hospitals, Bhubaneswar, Odisha. Sir, over to you, please.
Yeah, can you see my full screen?
Yes, sir.
Okay, so my topic allotted to me is advancing care in HER2-positive early breast cancer. So already we have discussed that it is one of the most common cancers among females, and all the guidelines they recommend neoadjuvant chemotherapy. So that part also we are very clear. Suppose the tumor size is more than 2 centimeter, or any node is positive, then we have to consider neoadjuvant chemotherapy as per the ESMO and the NCCN guidelines. And these guidelines are based on some evidence. The evidence comes from the Neosphere, where it is shown that THP is better than your TH. So dual NTR2 is better than single NTR2. So that part is also very clear because it gives more higher PCR rates. And again, a train 2 is a trial that looked at whether we can spare the anthracyclines, though the trial design was a superior trial, but it showed that the PCR rates are almost equivalent. Non-infective anthracycline regimen cannot be claimed because it was a superior trial, but it gives some relaxation for somebody who is having a cardiac comorbidity. You can avoid anthracycline. Again, ADCs has been investigated in neoadjuvant setting, that you don't give chemotherapy, you give TD1 plus pertuzumab, and then go to surgery, and then continue TD1 plus pertuzumab, and the comparator arm was TCHP for 6 cycles, and then surgery, and then followed by HP. Unfortunately, the PCR rates were not great with TD1 plus pertuzumab, and hence TCHP or THP continues to be the standard of care, and you cannot give a TD1 plus pertuzumab as per the neoadjuvant strategy. So opportunities remain to improve the neoadjuvant treatment in HER2-positive early breast cancer. So whenever there is a residual disease, we understand that patients will have a poorer outcome. So lack of PCR is always a poor prognosis. And And patients who are having a larger tumor size or a positive nodal involvement, they are less likely to achieve a PCR. So higher tumor burden in the form of larger tumor size and positive nodal involvement that carries a poor prognosis. And so that was the requirement, that we have to improve the PCR and we have to improve the neoadjuvant strategy, based on which Destiny Breast 11 study was designed. It was a randomized global multicenter open label phase 3 study. And if we look at the risk of the patients that were included, they more than or equal to CT3, and N0 to 3 was included, or CT0 to 4 any node positive, that was included. So basically CT3 and any node, and if you have got any node positivity, then also it is included. And such kind of high risk population was included. And patients were randomized into 3 arms: TDXT plus THP, each 4 cycles, or a dose dense AC4 and THP4. And the third arm was TDXT 8 cycles. The TDXT alone arm was closed by the independent data monitoring committee because of the kind of multifactorial reasons: lower PCR rates, low likelihood of the TDXT alone that would be superior to DDAC THP. So that's the reason that TDXT only arm was closed out. And post surgery, again, somebody who was exposed to TDXT4 and THP4, they were given TDM1 if the patient is not achieving a PCR, and those who are achieving a PCR, then trastuzumab plus minus pertuzumab. So kind of a novel design trial, because there was no data such as TDXT4 and THP4, and then followed by TDM1. So, but that was a novel design because that was standard of care at the time the trial was designed. And looking at the primary endpoint was PCR by blinded independent central review. And secondary endpoint, again PCR, but this time YPT0 TIS is not there, and YPN0, and the EFS and OS were also included in the secondary endpoint. So looking at the result of the trial, so the study was positive. So neoadjuvant TDXT and THP demonstrated statistically significant and clinically meaningful improvement in PCR versus DDAC and THP. So TDXT has now come into the forefront in the neoadjuvant strategy, and the reason being the extra 11.2% of PCR in the intent to treat population. If you look at the HR positive, it was delta is around 9.1%, HR negative, the delta is 16.1%. So HR negative, definitely a clear winner out there, a delta of 16.1%. Even in HR positive, which doesn't respond well to chemotherapy, even in that setting, a 9.1% delta is very considerable. So coming to the residual cancer burden outcome, as you know, the residual cancer burden, which is 0 plus 1, is known as minimal residual invasive cancer. So even in residual cancer burden, the delta is to 12.2% in intent to treat population. HR positive is 13.3%. HR negative, it is 9.2%. So the RCB is much better with your TDXT. Looking at the safety summary, so patients who grade 3, if we look, lesser of neutropenia was definitely there with the TDHD and THP. And the main adverse event of special interest, the pneumonitis part, all grades for around 14%, but somebody who is having more than or equal to grade 3 is only 0.6%. So a low ILD or pneumonitis. However, the patients were screened very regularly and frequently for looking at the ILD part. So that part is important, and the LV dysfunction was not much. So there is a growing clinical interest in neoadjuvant de-escalation studies as well. So whereby aggressive treatments are minimized or omitted for select patients. So somebody who is achieving a PCR, or say somebody who is having a T2N0 or T1N0, T1CN0, in that case we do consider decreasing the intensity and the duration of the treatment. So that is also there, because the objective was toxicity and quality of life and cost. And if you look at the recommend the different post adjuvant or adjuvant strategies, somebody with a HER2 positive, then patients have to receive a TDM1 if there is residual disease, and somebody who has achieved a PCR, patients will be given a trastuzumab plus minus pertuzumab based regimen. So that's the kind of as of now that was the standard of care. And that standard of care was set up by your Catherine study, which looked at the if somebody is not achieving a PCR, you give them TDM1 compared to the trastuzumab in the patient in the comparator arm. So primary endpoint being IDFS and secondary endpoints being DFS, OS, and DRFI. And in the Catherine, if we look, very good data. At 3 years, the 77% in the trastuzumab arm and 88.4% in your TDM1 arm. Somebody who is not achieving a PCR, you give them TDM1, then extra delta of 11% is there at 3 years. And importantly, at 7 years, again, it is around 13%. So 67.1% versus 80.8%. So 13.7% extra benefit if you are giving a TDM1 for patients who are not achieving a PCR. So that made it standard as somebody not achieving a PCR post surgery in a HER2 positive, you have to give them a TDM1. And not only the not only the EFS, also the OS improved. So 84.4% at 7 years versus 89.1%. So 5% extra of OS is there. And this is the adjuvant data of affinity. Patients who are having a high nodal positive. So we used to give somebody who has done upfront surgery, and if you've got a high nodal burden, so in that setting, you have to give a trastuzumab plus pertuzumab. And again, you have got a IDFS benefit of around 3 to 4%, and but it is used mostly for patients who are having a high nodal burden. And opportunities remain to improve the post-neoadjuvant strategy in HER2 positive. So patients who are not achieving a PCR, they do bad. So that part is we know that. And the 3-year IDFS is something like around 77 to 88%, but we are not crossing beyond 90%. So we can improve on that part, especially in high-risk patients. So that based on that, the Destiny Breast 05 study was designed. So patients eligibility criteria: patient who has already been operated, and patient is still having a high residual nodal disease. So operable early breast cancer with axillary node positive disease YP N1 to 3 after neoadjuvant therapy, or patients who have undergone a neoadjuvant therapy because they were inoperable. So CT4 and any node positive, they were also included in the study. So if the patient is having a residual, and in that case, patient were randomized to TDM1 3.6 milligram per kilogram for 14 cycles, or TDXT 5.4 milligram per kilogram for 14 cycles. So it was directly comparing the standard of care TDM1, and the Catherine study was being challenged. So TDXT and the TDM1. So primary endpoint was IDFS, and key secondary endpoint DFS. Other secondary endpoints included OS and BMFI and DRFI and safety. So again, endocrine therapy was allowed, and RT was kind of at the physician's discretion. They could use a concurrent or a sequential strategy. Looking at the results of the Destiny Breast 05 trial, so in that case, IDFS, if we look, the delta is around 8.7%. So as I told you, the 3-year IDFS was pushed above 90%. It was 92.4% versus 83.7%. So clearly a fantastic result that looking at the 92.4%. So extra of 8% was gained if you are considering TDXT in this high risk population instead of a TDM1. So fantastic results. And what are the lesser IDFS? So what are the lesser events? So the distant recurrence was less, and as well as locoregional recurrences were less, and more importantly, CNS recurrences were also less. So these are accounted for the better DFS with the TDXT. And coming to the DFS, again, it was very similar, delta of 8.8%. And looking at the number of cycles, patients completed 14 cycles. So around 70%, 72% patients completed the TDXT in comparison to TDM1, 76.3%. So most of the patients, they were able to complete the 14 cycles. So that was good. And overall safety summary, again, if you look at the grade 3, it was 50% with TDXT versus 51.9% with TDM1. And if you look at the drug-related ILD or pneumonitis, it is 10.8% versus 2.5%. So it is all grade. And dose reductions or dose interruptions, it was around reduction was around 25% patients required a dose reduction. Death, it was around 0.4%. So we have to be very alert in that case. And even in TDM1, there was of 5% deaths were there. And adverse event of special interest ILD or pneumonitis, again 9.6% any grade, and grade 3 is around 0.9% ILD. And LV dysfunction, again, it was very similar to TDM1. So summarizing my overall slide, neoadjuvant therapy is now a standard of care. We understand that based on the Neosphere Trifina studies. So neoadjuvant, you have to give patients a dual NTR2, and patients have got opportunity to improve the neoadjuvant strategy. So Destiny Breast 11, that provides a better PCR. And so TDXT has come up now in the neoadjuvant setting, and guidelines recommend different post-neoadjuvant or adjuvant therapies depending on the tumor size in response to the neoadjuvant treatment. And TDM1 is recommended in the post. So that was there based on the Catherine patients who are not achieving PCR. We used to give them TDM1, but right now Destiny Breast 05 has come up, and patients who are having residual, so better to give TDXT in such kind of scenario to have a better DFS results. So with that, I conclude my talk. Thank you. I hand it back to the organizers.
Thank you, Dr. Panda, for your excellent presentation. We now come to the final scientific session of today's conclave. The topic for our case-based panel discussion is the right patient, right time. Case-based panel on management of HR positive, HER2 negative metastatic breast cancer. To moderate this session, I invite our program director, Dr. Sudhir Das sir. Joining him are esteemed experts, Dr. Sandeep Kumar Barak, Dr. Saini Banja, Dr. Debajyoti Maji, Dr. Kakoli Medi, Dr. Amitabh Chakrabarti, Dr. Nirmalaya Banerjee, Dr. Sayan Kundu. Over to you, Dr. Das. Sir, you're on mute.
Okay, done. Our CME is going quite late, so I'll not take much time to initiate the panel discussion. We'll be discussing that what should be the subsequent line of therapy for hormone positive and HER2 low uh, or ultra low metastatic breast cancer patients. Yeah. So, we have often a reservation that we want to go slow at the beginning, give some first line therapy, and there is one strategy that we often we have some reservation regarding the newer therapies, novel therapies, because they are expensive. So we keep those novel therapies uh, in reserve to use them in subsequent line, maybe in second line, in third line, because they are expensive. But what is a real world scenario? In a real world scenario, if you start treating 100 patients, 18% of patients, they will not be eligible to receive second line subsequent therapy because of their very drastically their deterioration of their PSE Cox score. Another 17% patients will be dropped out from your treatment uh, when they reach third line. So altogether, one-third of patients with hormone receptor positive, HER2 negative MBC will not reach third line of treatment. So if the clinician has reservation that whatever novel therapy, effective therapy is there, but it is because it has some cost issues, cost is a barrier, and let's start with some less expensive therapy first and keep the more effective but expensive therapy for future. Maybe that one-third of your patient will not be eligible to receive the effective therapy in future. So we know that earlier breast cancer were classified into four groups: luminal A, luminal B, HER2 enriched, and triple negative. But these days, there is a broad classification of HER2 low and HER2 ultra low. So most of the HER2 low and HER2 ultra low are, in fact, they are majority in the hormone receptor positive group. That is the luminal A and luminal B. So 60 to 65% of luminal type breast cancers are HER2 low, and another 20 to 25% of luminal breast cancers are HER2 ultra low. Only 10 to 15% minimal 10 to 15% patients of luminal types are actually in true sense HER2 absolute zero, which is there is no membrane staining at all. So, my first question will be to Dr. Sandeep Kumar Barik, sir. Dr. Barik, uh, in a hormone positive, metastatic breast cancer, hormone positive, HER2 negative, what is your first line standard treatment, sir? Dr. Sandeep.
Yeah, so in a metastatic HER2 positive, so first line is always I will go for a CDK4/6 with a hormone therapy, letrozole or
AI plus CDK4/6 inhibitor, right?
yeah.
And thank you, Dr. Barik. And what EFS you expect while you explain to the patient that you are hormone positive, HER2 negative MBC, you will be treated with hormonal therapy, you don't require chemotherapy. What is your expectation? What will be the median PFS?
Median PFS around 2 years, 2.5.
Perfect, perfect, Dr. Vadik. That is the experience, and that is the data also says so. Be it Mona Lisa trial or be it Paloma 2. Now, my next question to Dr. Shaini. Dr. Shaini Vanja, suppose that patient progresses after first line of AI plus CDK4/6 inhibitor. Then what is your standard second line treatment in your real world practice?
Generally, we go for a hormone therapy with targeted therapies if we get one, like if our ESR1 is present or PIK3CA is present.
Perfect.
Otherwise, if the patient is having a lot of visceral disease and very rapidly progressive, we generally go to chemotherapy for a chemotherapy like a taxane. And but now with this data of the recent, the data of Destiny 06, we can definitely think of Enhertu in this situation after a first line uh,
Thank you, Dr.
hormone
Shaini.
therapy.
Let me ask you that do you test ESR1 and PIK3CA at the beginning or once the patient progresses on first line therapy then?
No, actually, PIK3CA, I generally do it in the first line, before only, before starting the treatment. But for
Hmm.
ESR1, I prefer doing it after AI is given because then only the ESR1 is actually more effective or more, it makes more sense.
Yes, yes. So what Dr. Sayani was trying to say that she's absolutely correct that PIK3CA is a primary mutation, which is there at 30% of cases at the beginning. It is primary mutation. It is not an acquired resistance mutation. And what she is correctly saying that ESR1 is not a, it is very, it is not mostly a primary mutation. It is a acquired resistance mutations once the patient is exposed to AI. Now, where do you place fulvestrant in your second line, Dr. Sani? Suppose there is no PIK3CA, there is no ESR1, then what is your choice? Chemotherapy in second line or fulvestrant? Dr. Shiny.
Fulvestrant I may give, yeah, fulvestrant I may give with a mTOR inhibitor if the patient is having a low disease burden, but if the patient is having very severely progressive disease, I would
Yes,
definitely go for chemotherapy.
chemotherapy. And suppose the patient is progressing on mostly in the skeletal system. You have started fulvestrant. What is your expectation at fulvestrant? How long the patient will be progression free? What is your
It,
expectation?
it is around 6 months, 4 to 6 months around.
Yes, yes. So that is the point I wanted to highlight to all the panelists and all the faculties that we always we have a notion that hormone positive breast cancer patients are very good to treat. So they are very good to treat at the beginning when you enjoy 2 years of PFS, median PFS, as Dr. Barik was saying. But once they progress on the first line endocrine therapy, the standard endocrine therapy, fulvestrant, the median PFS, which was seen in Paloma 3, fulvestrant versus fulvestrant plus palbociclib. In that trial, fulvestrant, the standard arm patients had a PFS of only 4.6 months only. So that was the very discouraging result. So drastically, PFS in second line drops down from 28 months to just 2 to 6 months. And if you, in a subsequent line, again, you start using what Dr. Sahani was telling that if the patient is very symptomatic or visceral metastasis, then she will use chemotherapy. Then even with a single agent chemotherapy, you expect a median PFS of 4 to 8 months. So that is the real world scenario. Now, this is our first case, advanced breast cancer. She is a 71-year-old lady, patients with hormone receptor positive, HER2-low MBC. She had T4B, M1 disease, pleural deposits, lymph nodes, bones, suspected liver mets. ER was strongly positive, PR was also strongly positive, HER2 status was low. It was IC2 plus and FISH negative, Cas67 was 40%, grade 2. So we had our answer of the first question, how we do manage such a patient. Yes, AI plus CDK4/6 inhibitor. My next question will be to Dr. Devojyoti. Dr. Devojyoti, suppose you have tested biomarker PIK3CA mutation at the beginning and it has come positive. what will be then your first line treatment, Dr. Devajyoti?
Sir, even if it is PIK3 positive, I'll go with the CDK4 plus AI, sir.
Perfect, Dr. Devajyoti, perfect. In fact, there are subgroup analysis of those Mona Lisa and Paloma trial, that those showing that even in the presence of PIK3CA mutation at the beginning, which is a primary mutation, the benefit of adding CDK4/6 inhibitors are still there. So the first line treatment standard is still AI plus CDK4/6 inhibitor. Thank you, Dr. Devajyoti. Now, this patient was treated with letrozole plus palbociclib, denosumab, and she had a partial response. And as expected, after 24 months, CT was showing progressive disease, and it was a progression in lymph node as well as in visceral liver and lung. So this lady was treated with just like what Dr. Saini was telling, that what Dr. Saini was saying, that the patient had significant visceral mets, so she was started capecitabine chemotherapy. She had partial response, and then Dr. Amitabh, can you mute for some time?
Yeah.
Dr. Amitabh, please, can you mute yourself for some time? Then, after 5 months of capecitabine, again there was progressive disease at liver. My next question will be to Dr. Kakali. Dr. Kakali, maybe in second line, the patient in first line treated with AI plus CDK4/6, second line with capecitabine. Would you re-challenge with the CDK4/6 inhibitor plus third line endocrine therapy now? Like there is some modest benefit with continuing ribociclib in re-challenge who are exposed to other CDK4/6 inhibitor, like in what was seen in maintenance trial, but it was a phase 2
Yes,
trial,
sir.
small phase 2 trial, and very modest PFS benefit. Would you like to re-challenge CDK4/6 inhibitor, Dr. Kakuli?
So, sir, in this current scenario, I would in our setting we do not go for the mutational analysis at the baseline. So
Yes.
now we would do like for second line therapy, we would need to go through all the mutational panels, see if there are mutations that can be targeted. And with the current scenario, I think we have to act on the HER2 low status of the patient in this scenario now that she has also progressed on chemo and in primary endocrine plus CDK4/6.
Thank you.
But up
Thank
till
you.
now, yes, sir, we were doing the same thing. We would go for CDK4/6 inhibitor plus endocrine therapy or both, sir.
Okay. Okay. Thank you. My next question will be to Dr. Amitabh Chakraborty. Dr. Amitabh, will you consider NHER2 in this setting?
Yeah, definitely. I will have to consult the patient regarding the costs and also the probable side effects, and go for the baseline HRCT and PFT. If everything permits me to go for TDXD, I will definitely go for TDXD in this patient. If capecitabine was not tried in second line, I would have tried fulvestrant, definitely.
Okay.
But considering liver involvement and one line of chemotherapy already given, TDXD will be my drug of choice.
Thank you. Thank you. So let's see the evidence. This is the scientific evidence as shown by Destiny Breast 04. So Destiny Breast 04 was patients who progressed on hormone positive HER2, only HER2 low. Please note that in Destiny Breast 04, all the patients were hormone positive and HER2 low. There was no HER2 ultra low. Second is the patients progressed on at least one line of chemotherapy. And third, the hormone positive and hormone negative, both sort of patients were enrolled in this trial, Destiny-Breast 04. Hormone positive as well hormone negative. But of course, there was more major representation from hormone positive. I think that was somewhere close to around 80%. But hormone negative HER2 low patients were also enrolled. Now, the hormone receptor positive patients, the eligibility criteria was that they should be endocrine refractory. Like our what the patient we are discussing now. So this patient was perfect eligible patient for Destiny-Breast 04, hormone positive, endocrine refractory, and progressed after at least one line of chemotherapy. And look at the PFS difference. PFS was actually doubled, 5.4 months with chemotherapy and 10.1 months with TDXT. Look at the overall survival. Again, there is delta of 6.4 months, 7.5 months OS versus 23.9 months, close to 2 years. Across all the subgroups, Destiny-Breast 04 is showing improvement. And this improvement is in OS, not in even PFS, OS. What type of, what kind of HER2 low? Is it IHC 1 plus or IHC 2 plus or FISH negative? Both are showing benefit. Patients who had prior at least one line of chemotherapy or two or more line of chemotherapy, both are getting benefited. Visceral disease at baseline or present or not, all the patients are getting benefited. Look at the response rate. With chemotherapy, the expected response rate is nearly 16%. With TDXD, the response rate, objective response rate is 52.6%. My next question will be to Dr. Shayan. Dr. Shayan, uh, do you feel that this response rate is impressive and this response rate with chemotherapy in this setting is very, very discouraging, disheartening? 16% response rate, objective response rate. Only probably one or two patients out of your 10 patients will respond with chemotherapy. Here, half of your patients will respond. Dr. Shayan.
Yeah, definitely. The objective response rate with PDHD is definitely very heartening to see. With chemotherapy, it is very less, but in real life scenario, if you consider, the patient progresses on CDK4/6 AI and the patient is in visceral crisis, still in today's date, we are tend to using the chemotherapy with taxane-based chemotherapy rather than TDXT. I personally have not used TDXT in the second line in a patient of visceral crisis. I don't have any personal experience, but definitely chemotherapy we have experience.
Okay, you don't have any personal experience, but may I ask you a question? In your center, you are working in academic center, high volume center. Uh, are you asking your pathologist to provide you in this situation, progressed on first line endocrine therapy, that is this patient HER2 low or ultra low, or they are just providing a report that this is HER2
No,
negative?
they are already providing.
Okay. So they all are sensitized and
Yeah,
they are now
according to the CAP protocol.
they are on board, same board. Thank you. So this patient was counseled around the use of TDXD. What Dr. Amitabh was saying, that we need to educate the patient about the not only the benefit, but that this is a moderately emetogenic drug. It can cause nausea, vomiting, fatigue as well, and there is a 10% chance of developing ILD and pneumonitis. So we need to educate them that what are the symptoms that the patient is landing in ILD or pneumonitis. So these are the adverse events. We are repeatedly discussing these adverse events: nausea, fatigue, some transaminitis, alopecia, a little bit of neutropenia, anemia, and thrombocytopenia and ILD. But most of the ILDs are grade 1 or grade 2. Grade 3 ILD are very less. And these patients was evaluated for ILD, just like Dr. Amita was saying, that baseline CT and pulmonary function test was done. And the patient was started third line treatment of TDXD. So TDXD is moderately hematogenic drug, and that's why the ESMO and NCCN guidelines say that you need to use three drug combinations for anti-emesis prophylaxis, like 5-HT3 receptor antagonist, corticosteroid, and NK1 receptor antagonist. Look at the scans, serial scans after TDXD. A 3-month interval CT scan is showing beautiful regression of all the liver mets. Patient remained on TDXD. So, in nutshell, in HER2, it's the first and only HER2-directed therapy to provide significant survival benefit to patients with HER2 low MBC after progression on standard therapies, as shown in Destiny-Based 04, that the primary endpoint PFS is doubled, 10.1 versus 5.4 months. There is more than 6 months OS increment from 17.5 months to 23.9 months, close to 2 years, and 3 times higher objective response rate. Pretty impressive, 16% versus 52%. So now my question comes to Dr. Nirmalo. Dr. Nirmalo, in your you are working, collaborating with many clinicians, many clinical oncologists, medical oncologists. You are getting requests for reporting of HER2 low and HER2 ultra low. Can you give once again sensitize us that what is HER2 low and HER2 ultra low?
Yeah. So good evening, Sudipda. I'm watching you after a long time. So the basic change is, I would say, that the pathologist should spend some extra time on 40x, that is the high power. Previously, it was a very much black and white reporting. So this Destiny, after this Destiny trial, it has changed a lot. Not only it has created a third space in between a typical positive and a typical negative. So to identify the gray zone, the further subclassifications has been done, and it has divided the HER2 low into further ultra low category. So HER2 low is when these circumferential membranous positivity would be covering at least more than 10%. And in ultra low, after scanning the whole slide and also discussing with your colleague who is also seeing the same slide, that these coverage is less than 10%. So the difference is between more than 10 and less than 10, and the circumferential and the membranous staining. But the issue is two here as far as the HER2 reporting in our city, in our state is concerned. People are not using the clones which are being mentioned by the CAP or ASCO CAP protocol, that these are the 4-5 clones that you have to stick to. These clones, then only you can report this low, ultra low, or positive or negative, or these equivocal. So before you go to the conclusion, you must mention into your report that the clones have been prescribed by the ASCO CAP, have been used in your reporting. And the second part I would like to mention here, that when you are writing ultra low, when someone is writing ultra low, a footnote has to be there mentioning this, that incomplete staining, membranous staining covering at least less than 10% area. That is why so the clinician will get a confidence after seeing that report. So these two things has to be mentioned. Until and unless there is no use, this therapy is so costly, we have to do justification to that.
Thank you, Dr. Nimalu, for elaborating so well. And even I learned some few points that we clinician need to look at, that which clones are pathologists using. That is also important, which I was also not aware of. Thank you, Dr. Nirmalu.
Thank you. Thank you.
So yes, so he beautifully described that what is the importance of using a 40x microscope. You can't rely only on 20x. And now we'll come to another case which is ultra low. This 45 years old lady, hormone receptor positive, HER2 ultra low. This lady received first line letrozole, ribociclib, and ovarian suppression because she was premenopausal, 45 years. This partial response. Now she progressed and she has visceral mets, not only visceral liver mets, she is in visceral crisis. But she's HER2 ultra low. Shanda, Dr. Shayan, do you consider this case for chemotherapy? Yes, patient is in visceral crisis, or you feel that TDXD will do a better job in this situation?
Yeah, definitely. After the DB04 trial result, we would rely on the PDXD. Definitely, yes.
Yeah, thank you. Thank you. This is well covered by Dr. Nirmalo. So, let me once again highlight that this case is slightly different from the first case. The first case was also HER2 positive. No, sorry, hormone positive. This is also hormone positive. The first case was one line of hormone therapy and then progressed on one line of chemotherapy, capecitabine. Here the patient is chemotherapy naive. The patient progressed only on hormone therapy. And this was the criteria for Destiny Breast 06. So Destiny Breast 06, how that is different from Destiny Breast 04, that Destiny Breast 06 only enrolled hormone receptor positive patients. No hormone negative patients were enrolled. Second, the patient in Destiny Breast 06, both low and ultra low, both sort of patients were enrolled. Third, in Destiny Base 06, patients who are chemotherapy naive, like this patient, were also enrolled. So the patient who progressed on any endocrine therapy were enrolled. And in this situation also, it is seen that there is a clear-cut benefit in PFS, 8.1 months versus 13.2 months. So, and so we discussed these issues that so look at the coming to the data over in Destiny Breast 06 overall study population, there is a PFS benefit. HER2 low population, there is a PFS benefit. Even HER2 ultra low, in that setting also there is a PFS benefit. Look at the hazard ratio, almost same, 0.64, 0.62, 0.76. How convincing is this data, Dr. Amitabh? How convincing is this data that any chemotherapy naive patients also you can treat with TDXT? Dr. Amitabh.
Look, personally, I am a little susceptible for these ultra low patients because I am suspicious of the reports which we get from different labs. So
fine, that is different story. Suppose, Dr. Amitabh, suppose you got the report validated by Dr. Nirmalo himself. Then, as a clinician, what will be your take on?
Definitely, after DB06, there is no doubt that we can go for TDXD in these patients because almost for low and ultra low, all the outcome parameters are almost same. So definitely we can go for TDXD in these patients.
Thank you. Thank you, Dr. Amitabh. Next question to Dr. Kakali. Dr. Kakali, in Destiny Breast 06, even look at the objective response rate. Patient progressed on hormone therapy, chemotherapy naive. If you are tempted to use chemotherapy, look at the objective response rate. Only 1 out of 3 your patients will respond. 34%, 35%, 30.8% response rate in chemotherapy arms. But look at the TDXD response rate, 62, 62, 65. Over, are you convinced with this data?
Yes,
Dr.
sir.
Kakli?
Sir, I agree with you. The numbers are quite convincing, and Yes, we would definitely like to uh, treat our patients with this current regimen. Yes, in this setting. Yes, sir. I agree with
Yeah, thank you,
what
thank
you
you,
were
Dr.
saying. Yes,
Kakuli. And even NCCN also have recommended that in second line setting, if patient is HER2 low, TDXD is category 1 and preferred in this setting. So this is ESMO metastatic breast cancer guideline. Patients who are HER2 low or ultra low TDXD, or if not HER2 negative, then some role of taxane. If prior chemotherapy used, then you follow destiny base 04. If no prior chemotherapy, even you can quote destiny breast 06. Chemotherapy naive patients, PFS of 13 months and a response rate of 62%. So I will again come back to Dr. Shiny. Dr. Shiny, a patient who progressed on one line of endocrine therapy, if we are using fulvestrant, the median PFS is just 4.6 months. If we are using chemotherapy, the median PFS is also not that great, 8 months. So in this situation, TDXD can achieve a 13 months of PFS and objective response rate of 62%. But what about the survival data? Will you ask for survival data?
Yeah, definitely I would ask for the survival data. But another point is also like if the patient is having lung metastasis, huge pleural effusion, lung comorbidity in that sense. In those cases, also I'll be a little skeptical about using THCT. And
What about liver
otherwise,
metastasis?
liver metastasis is fine. That is still okay. I will go for a THCT, but only for the lung component, I would be a bit skeptical. And otherwise, one more thing is that if the patient is on visceral crisis, I would really prefer THCT. If not, if the patient is
Because
not
of faster
really,
downstaging,
yeah, yeah,
with a higher,
yeah,
very significantly higher objective response rate.
yes. Another one thing also I feel generally these the patients who progress on the hormone therapy suddenly deteriorates very fast. So sometimes the PF also becomes very poor in a very short span of time. In those patients also, I would be a bit skeptical, just using THCT in the second line after endocrine therapy. So these are some ifs and buts. Otherwise, I find this GB06 very impressive, and I would really go for THCT.
So then the argument can be that in this, that is the situation at the beginning. First slide I have shown that one third of the patients will not be eligible for third line treatment. So Dr. Devjyoti, maybe that after one line of hormone therapy, maybe these patients are can be treated with the distinct 06
Yes, sir, definitely. Even after first line failure of hormone therapy,
hormone
this
therapy.
patient can be given TDXT if the
And
pulmonary function is good enough.
And Dr. Sandeep, thank you, Dr. Devjyoti. Dr. Sandeep Barik, will you not do BRCA analysis before starting this therapy? Because if BRCA is mutated, then probably the next line should be Olympiad regimen.
Backup, I would be tempted to do, no doubt about that. But
Yes,
if it is
because
a
Olympiad is there. Olympiad is showing that there is PFS benefit with olaparib compared to treatment physician's choice.
Yes.
Okay, with this, I want to thank you everyone, all my panelists for patiently listening to, patiently getting engaged in this conversation. Our CME just got very late, and over to the organizer.
Thank you, Dr. Das and our esteemed panelists for such an engaging and enriching discussion. The practical experiences and expert opinions shared today will undoubtedly benefit all our participants. To conclude today's scientific program, I would like to call upon our program director, Dr. Sudeep Das, sir, to deliver closing remarks. Over to you, sir.
Yeah, thank you all the faculties for sparing from your valuable time, busy schedule on a weekday, and thanks to IAIO for giving this platform to us. Thanks to our partner AstraZeneca for giving us providing us scientific evidences. So it is for sure that treatment of not only HER2 positive but hormone positive and even triple negative breast cancer management landscape is changing very fast, and over time eventually ADC will play a big role in future, not only in HER2 positive, but also hormone positive as well as triple negative breast cancer. So with this, I want to thank you all once again and very good night. Wishing you all good night. Thank you.
Thank you very much, Dr. Das, for your inspiring concluding remarks. As we come to end of today's breast cancer conclave, I would like to express my sincere gratitude to all our esteemed speakers, moderators, panelists, and delegates, and moreover, our program director for making this scientific meeting a great success. A special thanks to AstraZeneca and everyone working behind the scenes for ensuring the smooth execution of today's program. On behalf of IAIO, thank you all for your participation and continued commitment to advancing oncology education. We look forward to welcoming you again at our upcoming IAIO scientific programs. Have a wonderful evening. Stay safe and thank you once again. Good night, all.
Good night. Thank you. Thank you.
Thank you so much. Thank you, everyone.